the visuals, but you can put it just beside your chair.
Oh yeah, okay.
No, they were very nice to us. We paid for 800, but they gave us 200 more at the back.
So we registered the full capacity card.
Yep. Oh. That means that most of the people have come in, so I'm just watching. Yep. Yeah. Okay, welcome. I'm just waiting for the last few people to filter in, but very pleased that you can all be here today. For those of you who are busy and confused, this is the myeloma session. Treatment advances in multiple myeloma, expert perspectives on translating clinical data into practice. And we really do want to focus on that last part, translation into practice. So let me just go through the faculty and panel. We're very, very pleased to have such a distinguished panel for you today, similar to each year, actually. So I'm Brian Durie, and you can see my affiliations there. And I actually do have some disclosures which are not listed here for research activities. Very pleased to welcome Vincent Rajkumar, whom most of you know very well, I'm sure, from the Mayo Clinic. To his right, we have Shaji Kumar, also from the Mayo Clinic. Very pleased to have Vincent with Shaji with us this year. Philippe Moreau, professor of clinical hematology in Nantes, France, very much involved with the IFM activities. Very pleased to have Philippe. Jesus San Miguel, well known to all of us for sure, who is, as you probably are aware, now the Director of Clinical and Translational Medicine in Pamplona versus Salamanca, where he's been for so many years. And his colleague, Bruno Paiva, also in Pamplona. So, our distinguished faculty. The format this year is slightly different, and I want to draw your attention to a few points. The first thing is that you may have noticed a little bit of an innovation. The keypad that you will use for the ARS is actually on the back of the chair in front of you. So that's yours. The one that's on the back of the chair in front of you, that's for you. Except for the front row, and hopefully you found yours on your seat. So there will be case presentations. There are 4 topics, and each topic will have case information. This year, I would mention that we provided you perhaps a little bit more detail and information than we may have done in the past about numbers and cytogenetic information, and so I would encourage you to pay attention to some of those details because that does relate to the answers. Another innovation this year is after you have voted, the faculty have pre-voted. And so you will see immediately what the faculty gave as their answer to these questions. After that, there will be a presentation of the data that would support and justify the answers. After that, there will be a discussion in the panel, but after each of the topics, we are going to be taking questions as we go through. And so if you are thinking about asking a question, we will do it after each topic. And then we have something that's new this year. At the end, we will have a little bit of a wrap-up session where we will present some treatment algorithms. In fact, Vincent Rajkumar will present some kind of proposed or suggested treatment algorithms for upfront and for relapse disease, which we think could be quite helpful takeaways for the session. And then we will close by drawing attention to some ASH abstracts dealing with new therapies that will be presented this year. Okay, so what are the topics for this year? The 4 major topics: diagnosing myeloma, when should treatment be initiated? So we've moved from diagnosing it and being sure about the diagnosis this year to talking about should we start the treatment. Then the second topic, should we be using risk-adapted therapy in clinical practice based on cytogenetics or FISH, based upon age and comorbidities? Then a key point, which has been controversial in recent years, how should we use maintenance for patients in clinical practice? And then the final main topic, which is especially difficult, I would say, right now with the approval of so many drugs in the relapse setting, how do we choose the best treatment regimens for relapse and refractory disease? And then, as I mentioned, the closing session, where are we now and where are we going with care for myeloma patients? Okay, so as we get started, the first topic, which will be covered by Vincent, diagnosing myeloma, when should treatment be initiated? Just as we're getting started, we do have an ARS question, so at this point you'll need your keypads, and it should click forward to that now. Yes, so the first question is just to get a sense of how many patients do you see in your practice? How many myeloma patients do you see in your practice? So do you see a small number, less than 10, 10 to 25, 26 to 50, 51 to 100, or over 100? So I suspect not too many of you are seeing over 100, but we'd be interested in the lower ranges there. So if you go ahead and answer this first question. All right, so 16%, over 100 a year, so that's quite, and then another 40, so that actually 30%, 50 or over 100. So this is great, significant active practice with myeloma. Okay, so the details for the first case, and so this is a case that is related to does the patient have a condition where treatment would be initiated? So this is a gentleman found to have a smallish monoclonal protein, 2.5 grams per deciliter, during workup for fatigue. This is an IgA lambda. Hemoglobin, creatinine, calcium are normal, so basic CRAB features are negative. Skeletal survey also negative. You'll notice that the serum free kappa level, 1,250 with a reduced serum free lambda at 10, giving a ratio of 125. The PET CT, no evidence of increased uptake or lytic bone lesions on the CT portion of the scan. MRI of the spine and pelvis, no focal lesions. The bone marrow biopsy did reveal 40% plasma cells, lambda, with FISH showing a 414 translocation. Okay, so some important details to ponder. So what is your diagnosis for this patient? Is this active myeloma, Is it smoldering myeloma? Is it light chain smoldering myeloma? Is it MGUS? Is it monoclonal gammopathy of undetermined significance? Or is it an unusual case of perhaps osteosclerotic myeloma? Or maybe you're not sure. So if you could answer this question. All right, fast apparently. All right, so 49% say it's active myeloma, 35% smoldering, 9% light chain smoldering. Okay, so this is an interesting distribution for Vincent to comment upon. Okay, so the faculty all said that this is active myeloma. So was a 49% concordance right there. So Vincent, I'll invite you to come up and lead us through. Oh, sorry, one more. I'm so sorry. Yes, so if in making your decision, what was the specific feature that made this patient meet the diagnosis that you selected? What was the crucial test? Elevated free light at 125, the T414 translocation, 40% bone marrow involvement, IgA subtype, or the age of the patient, or unsure. So if you could answer this, what guided you towards the selection for your diagnosis? Okay. All right, so 61% selected the elevated free light ratio, 29% the 40% bone marrow involvement, the two main things. So very, very interesting to see those 2 points. So thank you for that. I'll now turn it over to Vincent to explain how the faculty approached this case. Please welcome Vincent Rajkumar.
When should treatment be initiated? So, this is really bad myeloma. You have extensive bony and extramedullary disease on the left-hand side, and then you have cast nephropathy on the right-hand side. Obviously, this patient, all of you would treat. This is a very easy question for you. The problem is that myeloma, until recently, required end organ damage like this in order to be called as myeloma. And it basically left us with a catch-22. None of us wanted to diagnose and treat patients like this, but at the same time, we weren't able to prevent these things from happening, because if patients had none of these features, like the patient we had with a normal CT scan, a normal MRI, no anemia, hypercalcemia, renal failure, then we just sit and watch. But we watch for what? This patient had a free light chain level of 1,250. The first time you diagnose myeloma would be when this cast nephropathy happens. By then, it is too late. It is too late to save the kidney in many of these patients. Only half would recover even if you give them the best treatment. And we've found that many of these patients will never get a similar survival to patients without renal failure. What I'm going to show you or walk through you in the next few minutes is why we changed the diagnostic criteria for myeloma. What is the rationale? What is the basis for these changes in terms of the evidence that we needed to accumulate? And then give you an algorithm for practice in terms of how to approach these patients. One of the reasons for the madness, which is you might ask, why are we waiting and waiting and waiting to start treatment for patients who have a clonal plasma cell disorder and 40% plasma cells in the bone marrow? It's because there are pre-malignant conditions or precursor conditions where patients can go for many, many years without needing therapy. So for example, if you look here, Not everybody who has a clonal plasma cell disorder progresses. MGUS patients, only 1% each year progress to myeloma. So there's no point in treating these patients. Even smoldering myeloma, if you look after 10, 15 years, there's still a quarter of patients who don't progress. They just stay there. So the whole idea was that we cannot call all clonal plasma cell disorders as malignancies and start therapy, because many of these patients may just be just fine without any therapy. The other problem we had was it was just impossible for a pathologist to determine by looking at the microscope or by doing any sophisticated tests which patient had myeloma, which patient had smoldering, which patient was MGUS. It was not possible to do by pathologic examination. What we were left with was we needed to do it only by end organ damage. So if you had CRAB, you had myeloma. If you had no CRAB, you didn't have myeloma. So it was a clinical pathologic diagnosis. And we did separate MGUS from smoldering myeloma because MGUS is only 1% per year, smoldering is 10% per year, so we needed to have some way of differentiating the two. We didn't want to focus all our attention on prevention on the MGUS patients. So we basically divided that group arbitrarily based on bone marrow plasma cell percentage and the M spike. So life was simple. And let's examine the group of smoldering myeloma patients, because this is the group that we would rather save, meaning prevent them from getting end organ damage in a timely manner. All these years, there were 3 reasons why we didn't want to treat smoldering myeloma. Number 1, we didn't have good treatments. We had melphalan, prednisone. It was too dangerous to treat patients with smoldering myeloma with those drugs. Number 2, we knew many patients can go for many years without therapy and without progression, and we didn't know who would go for a very long time without progression and who would progress very rapidly. So we didn't have a way of telling who's who. And thirdly, we didn't have any actual proof from randomized trials that early therapy actually matters. People tried with melphalan, steroids. In those studies, nobody showed that patients lived longer because they got early therapy. So these 3 factors prevented us from actually engaging these patients and initiating therapy. I will show you why all these 3 reasons why we didn't treat smoldering myeloma are no longer true. Number 1, we actually have a lot of good drugs now for myeloma. Some of them work extremely well, are very amenable to early therapy, can be taken by patients without losing their hair and having horrible side effects. So it's something that we can actually do. Number 2, we do have biomarkers right now, as I will show you, many biomarkers that can tell us which patient with smoldering myeloma is likely to stay smoldering for decades and which patient is going to progress quickly. And number 3, and this is the most important thing, we have data from the Spanish trial that early therapy can indeed prevent progression. As you can see here, the observation group progressed as expected over a 2-year period. Half of them progressed over a 2-year period, whereas the treatment group went on for a very long time without progression. More importantly, the Spanish group also showed an improvement in overall survival with the use of lenalidomide dexamethasone for the treatment of high-risk smoldering myeloma patients. Now, over the last 3 or 4 years, Dr. San Miguel and his colleagues and Dr. Mateos have heard many people have concerns about how to interpret this trial. But to me, one thing this trial showed was that it eliminated any fear that I would actually be causing harm to the patients. This trial showed an improvement in overall survival with early intervention, and I could rest happy knowing that at worst it was no good, but at best it could actually save lives. It's very unlikely that early therapy is actually going to cause people to die sooner. Based on these 3 factors, we have a better understanding now of what smoldering myeloma actually is. There is no biologic smoldering myeloma. There's no in-between stage between MGUS and myeloma, which is smoldering, and some patients are going to progress every year. Rather, it's a good understanding right now that what we currently call smoldering myeloma is actually a mixture of 2 types of patients. Half of the patients with smoldering myeloma actually have MGUS. They're going to progress very slowly. It's a clear pre-malignant stage. Half of the patients with smoldering myeloma have myeloma, except they don't have the CRAB features. If we can only tell who's who, then we can treat the myelomas and leave the MGUS patients alone. This is the major paradigm shift in our understanding of smoldering myeloma, that it's not a biologic stage in between a polyp and a cancer, but rather a condition where we are not sure whether the patient actually has cancer or not, and so we are just having to use some crude techniques and clinical markers to differentiate. Because we identified some highly specific biomarkers that can tell who's who, the International Myeloma Working Group a couple of years ago updated their diagnostic criteria for myeloma, and that is the basis of the case that we heard today. There were three main changes made to the diagnostic criteria. Number one was bone marrow plasma cell percentage more than 60%. When we looked at patients who had what looked like smoldering myeloma, no CRAB features, MRI negative, everything negative, and they had more than 60% plasma cells, they did not do well. They progressed very rapidly, as you can see. If you call them smoldering here and decided not to treat, they crashed. They progressed so fast that by 2 years, 90% had progressed. This was confirmed on 2 other studies. Similarly, with free light chain ratio, if the free light chain levels were so high, the normal light chain ratio, if you do involved over uninvolved, is less than 2. If it is 8 or more, it's high risk. But if it's 100 or more, that is a patient waiting to get myeloma very, very quickly. So this is, again, something that was confirmed in another independent study, that patients with a free light chain ratio, like the patient we had, with more than 100, these are not the patients who are going to wait for 10 years and not progress. Thirdly was focal lesions on MRI. If you had more than one focal lesion, and these are not lytic lesions, these are focal bone marrow changes. If you had more than one focal lesion on the bone, on the MRI scan, even if the CT scans were negative, patients will progress and progress at a rate of 70 to 80% within 2 years. And that is shown in this slide. So these 3 criteria made us update the diagnostic criteria for myeloma, whereby myeloma can now be diagnosed by the presence or absence of any one of these 7 myeloma-defining events. CRAB features, that's hypercalcemia, renal failure, anemia, or bone lesions that are related to the plasma cell disorder, still count as myeloma. But in the absence of CRAB, a patient who has 60% or more plasma cells, or more than 100 light chain ratio, or more than one focal lesion on MRI, is automatically considered as myeloma. And that is why this patient was called myeloma, because the patient had a free light chain ratio more than 125, more than 100. So myeloma now is differentiating patients who have a myeloma defining event, which this list we expect to grow. As we find newer and newer biomarkers, this list will grow so that we can prevent end organ damage. And then MGUS and smoldering myeloma are defined by just absence of myeloma defining events. And we continue to split MGUS and smoldering. Now, there is another major change that was made in the diagnostic criteria besides the 3 biomarkers that I mentioned. And that was that we can diagnose myeloma using CT scans. In fact, many of us recommend a low-dose whole-body CT scan instead of a skeletal survey to diagnose myeloma. In fact, a number of patients who you would call smoldering may actually have quite clear lytic bone lesions on a CT scan if you had done them. By watching them, you're just going to have a problem with a pathologic fracture or some other problem. So the diagnostic criteria changed to say that we can now use CT scans and PET CT scans to diagnose bone disease in addition to skeletal surveys. So use whichever is available to you, but we prefer CTs, whole body low-dose CT or PET CT if possible. This, I think, will spare many patients who are wrongly classified as smoldering from progressing fast. This is important. When we had only the CRAB features, you always remember we had an underlying disclaimer: hypercalcemia, renal failure, anemia, bone lesions felt related to the plasma cell disorder. That is the line that gave you the power of judgment. So you could decide this anemia is from iron deficiency, it's not from myeloma, I'll just call it as MGUS and watch. Similarly, we have to exercise judgment even now. Occasionally, I see a patient with very high light chain levels in the serum, But when you do the urine, there is no measurable monoclonal protein. These are patients that are different. They have something wrong with their light chains. It doesn't get excreted. They are not the patients we want to treat. Similarly, there are patients who you may have watched for many years with a high light chain level who have done just fine. They are not the people we are going to target either. So exercise judgment, just follow the criteria without thinking about the particular patient in front of you. All that I mentioned so far applies to about 15% of smoldering myeloma patients. About 15% of smoldering myeloma patients will meet one of the new criteria. It's possible that some of these other patients will be captured by the CT scan, but it still leaves the vast majority of patients with smoldering myeloma in the smoldering myeloma category. They don't meet the high-risk definition, ultra-high-risk definition. They don't have symptoms, but yet in this group, you can divide them into two. One is a group of smoldering which has a risk of progression of like less than 5% per year. And the other group is the high-risk smoldering myeloma. This high-risk smoldering myeloma group, they have a risk of progression of 25% per year. The ultra-high-risk group that we relabeled as myeloma, this group of patients have a risk of progression of 40% per year. We are calling them myeloma now, but that's only 10%. This 25% per year means a median time to progression of 2 years. Half the patients would get myeloma within 2 years. What do we do with this group? That's the big question. Do we treat this group? Like I said, everybody would treat the first patient I showed you with extensive bone disease or renal failure. Everybody would probably treat patients who meet these criteria. But what do we do with high-risk smoldering myeloma patients who have a 25% per year risk of progression? This is the group that was studied in the Spanish trial, the high-risk group. And they found that Lendex can delay progression and perhaps improve survival. How do we identify who are the patients with high-risk smoldering myeloma from patients who are not high-risk smoldering myeloma? These are about 6 or 7 risk factors that we have published in a recent paper. Each one of these risk factors is associated with a median time to progression of 2 years. So if a patient who has what you think is smoldering myeloma has any one of these, they are found in many studies to have a 25% per year risk of progression equal to about a 2-year median time to progression. This includes patients with a very large M spike, more than 3 grams, absence of normal plasma cells and immunoparesis by flow, abnormal free light chain ratio, more than 8 but less than 100, deletion 17p, T414, 1q amplification, the IgA type of myeloma, smoldering myeloma, increased circulating plasma cells and evolving pattern. The patient that we had fulfilled the criteria for myeloma because of the 1,250 free light chain ratio, but the patient also had high risk features other than that. The patient was IgA, the patient had a T414 if I remember right. So that patient was already high risk. You would be, if the patient's ratio was lower, you would still count that patient as a high risk smoldering. The question is, what do we do with this group? And I will close with how do we manage these patients. First things first, this high risk smoldering myeloma patient population, we have now one randomized trial that says that early therapy can potentially save lives. It'll be nice to have one more trial to answer that question. And that trial is nearing completion. We need only about 10 more patients and this trial will close. It's going on in the US, expected to close within the next month or two, led by Dr. Sagar Lonial. It's comparing lenalidomide to observation. When this trial closes, we will have 2 trials that would have looked at the question of early therapy with lenalidomide and smoldering myeloma. How do we manage these patients? If you have a patient with potential new myeloma or smoldering myeloma, how do you approach them? Clearly, if the patient has a myeloma defining event, you would treat as myeloma. Similarly, if the patient doesn't have a myeloma defining event, I told you we need to classify them into high risk or low risk based on the list of criteria that I provided. If the patient has low risk smoldering myeloma, that is more or less like a patient with MGUS, and no one is recommending therapy for these patients. These patients should be observed. If the patient is a high-risk smoldering myeloma patient, such as the one that would have met the criteria for the Spanish trial, Currently, the recommendation is still enroll in a clinical trial or observation. This is where we stand at this point. I would like to make a provocative proposition. I am very scared about these patients. These patients could end up with acute renal failure or have a bad pathologic fracture any day, and it's a 50-50 chance in the first 2 years of this happening. It's too high of a risk. So it is in this paper, and I will show this to you as a gray area. If such patients have more than one risk factor, or they are actually evolving, I am now considering therapy for these patients based on the Spanish trial. So I will close with that and then hope to have discussions with my colleagues during the panel discussion time. Thank you.
Thank you very much, Vincent. As I said, we are open for questions from the audience after each of these cases, as well as the panel will discuss. So I don't see anyone at the microphone right now. So any comments from the panel? Are there any? We all voted that this would be a case that we would treat like myeloma, but any comments about the use of the new criteria, the MRI or the free light or the percentage of plasma cells?
Just want to highlight one point that Vincent stressed on, which is the using the clinical judgment in these patients. And I think it's very, very important. Often when especially if your practice has very few of these patients, you often tend to follow the criteria verbatim, but I think clinical judgment is important. I also want to highlight specifically the free light chain ratio criteria, because that is probably the most controversial of the three things that were added on. And there are clearly a subgroup of patients out there who don't excrete light chain in the urine. They tend to have high ratios. And so that has to be taken into consideration. Also, patients who you have been following for a long time, just because you already had these criteria 2 years ago now, just because it's been published doesn't mean that patient has to get started now, because that's a totally different patient than what was studied for the purpose of developing these criteria.
Right, and if there's any doubt, I think one thing that you put into the paper, Vincent, is to repeat. Do you want to talk about that, the follow-up testing?
Yes, so when in doubt, always repeat. The MRI scan, for example, if it shows focal lesions, but you're not sure whether they're focal lesions or not, repeat them. Repeat the MRI in 3 to 6 months. There are data showing that a change in the size of the lesions or a change in the number of the lesions is highly predictive of who's going to develop disease progression. So right. That's one. We also have data now published in the Blood Cancer Journal about evolving criteria. If the M spike increases and the hemoglobin drops around the same time by 0.5 gram or more, those patients are going to get myeloma very quickly, CRAB features. And so you do get a lot of benefit by just repeating the test in 3 months in cases where you're in doubt about whether this is myeloma or not.
Thank you. So we have a question at the microphone here.
Thank you, Vincent. Excellent talk. Ed Libby from Seattle. Wanted to ask you, you had commented on looking at light chains or Bence-Jones proteins in the urine to help you to decide what the risk was for the patient. If you could talk a little bit more about that and your reasoning, I'd be delighted to hear about that. It's something I've struggled with and wondered how to use.
Yep.
Okay.
So what Shaji and I have found is that there is a subset of patients, probably, 15% or so, who have high levels of light chain in the serum, but because of dimerization or something, the light chains don't get excreted in the urine at all. So these patients are not at risk for CAS nephropathy. So if you suspect a patient's got 1,000, 2,000 milligrams per liter of serum-free light chains and ratio very, very high, but when you do the urine electrophoresis for confirmation and there is no monoclonal protein or only a trace monoclonal protein, you have to be suspicious that this is not a patient where the high levels of light chain indicate a dominant, huge clone of myeloma cells, but rather a failure of the kidney to excrete the light chain. So that's where you exercise judgment and you say, the urine is not correlating what the serum results are. I can't give you a magic number, but it's usually cut and dry. I mean, you can see it very clearly that this must be a dimerization problem where the light chains are not getting excreted. That's why they're accumulating.
Excellent.
Okay,
Thank you.
thanks. And one more question on the right here.
Hi, thank you. Abulafi, also from Seattle. Could you just spend a moment and talk a little bit more about CT PET versus MRI? I understand CT PET might pick up a plasmacytoma, but aside from that, do you have a preference of one over the other? Thank you.
Another excellent question on the use of the right imaging modality. I'll just tell you at least what I practice, and then we can hear from my colleagues as well, because this is controversial. I don't like to diagnose solitary plasmacytoma or smoldering myeloma without the use of a good imaging study such as a whole body CT or a PET CT. Because if you miss the diagnosis, the consequences are quite grave. You don't want to call it as a solitary plasmacytoma when the patient actually has myeloma. And you don't want to call it smoldering when the patient actually has lytic lesions. So I do prefer one of those two. It really depends on the reimbursement. We are able to use a low-dose whole-body CT at Mayo very easily. Some other places, a PET CT is easy to use. Pick one of those two and do it. Now, if those are negative, if you think the patient has smoldering myeloma but the CT scan is negative, then it is reasonable to do an MRI of the spine and pelvis to look for focal lesions. Because there might be patients who have multiple focal lesions on MRI that simply are not visible on CT or on PET CT. So it is more work, it is more expensive. That is one option, is to add the MRI in such patients, to be really due diligence in. When I'm calling the patient as smoldering, I'm just basically telling them I'm not going to treat you. That is a big judgment call for a high-risk patient. And I don't want to be wrong in that call. And so if I'm able to do an MRI, wait for 1 month if the insurance companies don't balk at that. Just wait for 1 month and do an MRI, just to be sure whether there's a focal lesion or not. And you'll be more certain of the diagnosis. You'll be able to reassure the patient better.
Thank you. Jesus?
I would like to reinforce some of the comments that Vincent has made. First of all, regarding the CT. In the current smoldering Spanish trial, it is mandatory to do CT. And I can say that 20% of our smoldering patients have now been reclassified as active multiple myeloma without bone lesions in the conventional X-ray, but lytic lesion on the CT. Then I think this is very important. Another issue is the creatinine clearance. In the new criteria, not only to have creatinine more than 2, but also creatinine clearance is of value just to select patients that are candidate to receive treatment. And I also can share with you that the follow-up of the Geriatric, the Spanish trial that we published in the New England, has been updated recently in Lancet Oncology with a follow-up of 6 years, and we can confirm the benefit of early intervention in terms not only in PFS, but in overall survival, and it's larger the difference in overall survival nowadays. Then I am changing my mind. In the past, when we started the trial, I was really concerned about the possibility of selecting resistant clones by early intervention. Now, my thought is that probably by delaying treatment, you may favor the emergency of more dangerous clones.
Yeah. Just a comment, the IMWG has just completed a comparison of routine skeletal survey with a whole body low-dose CT, and Jens Hillengas has an abstract at ASH confirming what Jesus just said, that you can pick up actually 23% lesions on CT that have not shown up on regular X-rays. So very important difference there.
I do want to make one other comment. Some of you might be skeptical and wonder, what are the type of lesions are we picking up on CT? Are these really small dit cells and they don't really matter? No, we are actually picking up real myeloma. I've been just shocked at how much the skeletal survey can miss.
Right.
Vincent, I think the point that you have made about the clinical judgment is extremely important, because when you have a patient with anemia, you use the clinical judgment. When you have a patient with a very small lytic lesion, you should have the same clinical. And for the free light chain, I think it was a very, very important comment.
Okay, with that, I think we'll close. Oh, sorry? Is there another question? Okay.
Thank you. Dr. Rajkumar, you mentioned that patients with MGUS may happen to have a skeletal lesion as documented by PET scan. Since at least in my daily practice, PET scan is not a conventional approach in MGUS patients, I wonder what are the criteria to submit a patients to a PET scan with patients with MGUS?
So, all the discussion that we had was not for MGUS. It was for smoldering myeloma patients who have more than 10% plasma cells in the bone marrow. If you have a patient with MGUS, we actually recommend for low-risk MGUS patients, that is small, less than 1.5 IgG, normal light chain ratio, that you don't even need to do a skeletal survey. That is the IMWG thing. And if you've got a higher risk MGUS, you just do the skeletal survey and hemoglobin, calcium. This is not applicable to MGUS. MGUS is a very low risk of progression condition. We're talking about high risk smoldering myeloma, and that's the group that we are really anxious about preventing.
All right.
I have a comment,
Yeah, Bruno, please, yes.
Comment/question for the panel, which is that as we are seeing more and more clinical trials in high-risk smoldering myeloma, isn't there some homework to do for you regarding accurate criteria to include patients? Because really, if we look into the biomarkers that define high risk, and this could be more or less divided into those related to M component, cellular biomarkers, and then imaging, really only a few, and those related to the M component, have an automated interpretation of data and are standardized. So I think that as we move forward, there is also some homework to do regarding criteria for inclusion of patients.
For sure, I think that there's a lot of room for improvement.
Your point is very important, Bruno. We should enroll patients with exactly the same inclusion criteria into clinical trials because there is a gray zone, as mentioned by Vincent, regarding the definition of smoldering myeloma. But in addition, we are doing trials that are totally different. We've heard about the Sagar-Lonials trial in the US with a LEN single agent. That's very strange. We know that with Lendex, maybe we can have an overall survival benefit, but with Len alone, that's strange. On the opposite, we have a totally different approach in Spain, where they are proposing a sort of KRD plus stem cell transplantation in patients with smoldering myeloma in order to cure them. But we see here the limits of the definition of smoldering, uniform inclusion criteria, and trials that are totally different from one side the other side of the Atlantic Ocean.
Absolutely. I think that we're going to have to move on, but I think that this dichotomy of gentle treatment versus aggressive treatment with an effort towards possible functional cure and the like, very important question right now, which has to be answered within clinical trials. We'll cycle back to that. So that we move forward, let's come back to this particular case and see what you think about your answer now. So let's vote again, please. And do you think this patient actually did have active myeloma? Do you agree with the panel, or do you still disagree with the panel? So let's see. All right, we still have a few holdouts here, but you need to work on that, Vincent, okay? And then we have that second question. Yes, we got a green check mark there. And so what was the basis for that active myeloma selection? In fact, Vincent mentioned a couple of things.
If someone gets this wrong, I'm going to have to make them stand up.
Okay, so let's see here. Pretty good. There's still a few miscellaneous holdouts. I think they're still finishing lunch back there somewhere. But okay, well, thank you so much for that. What do we have here? This is the case example. I don't know what has happened there. I think we're through with this. If we can... There we go. All right. Don't know what was that little bit of a glitch there. So we're going to move to the second topic. And for this second topic, we actually have two presenters. Should we be using risk-adapted therapy in the clinic? And this is broken down into risk-adapted based on cytogenetics and LDH and age and comorbidities. And so we're going to discuss those two aspects separately. So, quite sure. Here we go. We need the case first. This is going to be how. Yes, you're mind readers. You can see the case. Yes. Okay. So we're thinking about risk assessment here. So what kind of risk factors does this patient have? So this patient is a young patient, 42-year-old man, presented with back pain, compressions of vertebra, especially T12, lesions on the MRI, mild anemia, white count fine, platelets fine, creatinine, calcium, LDH 378, beta 2 5.8, so those might catch your attention. Additional exams, the spike is 3.2 IgA kappa, some elevation in the kappa level, 34. 24-hour urine does have some M component in the urine, kappa light chain. PET scan shows diffuse lesions involving the axial skeleton, but no extramedullary disease. Bone marrow plasma cells, 40%, kappa chain restricted. Fish, you've got a trifecta there on the fish. You have monosomy 13, translocation 414, and also deletion 17p. So this particular patient was started on VRD, bortezomib lendex, a regimen that I particularly like. 4 cycles, so a standard induction of 4 cycles of VRD, and achieved no residual disease using a flow MRD test. Okay, so the question is, how would you approach this patient as the next therapy for this patient? The patient has achieved a CR with 4 cycles of VRD. So would you stop the bortezomib and continue just with lenalidomide maintenance? Would you stop the lenalidomide and continue with the bortezomib maintenance? Would you just stop all of the therapy and observe, since the disease is MRD negative? How about a single autologous stem cell transplant followed by bortezomib maintenance? Proceed to a tandem auto, or start a donor search and consider allogeneic? So quite a selection of options here for you to ponder. And you've got that G there for the unsure. So, how about that? So, D, a single autologous stem cell followed by bortezomib maintenance. All right, so very interesting, but with a minority voting in the other categories. Proceed to a tandem would be the next one that was selected. So what did our panel, our esteemed panel say? Okay, so very aggressive panel here, with only Vincent on the lesser side. Okay. Okay, well, Shaji is going to pick up the baton here and discuss how these decisions might have been reached. So please welcome Shaji Kumar.
Thank you, Brian, and good afternoon, everyone. The very fact that we are talking about risk assessment in myeloma itself reflects the progress that we have made in this disease in the past decade. When myeloma was, originally the term multiple myeloma was coined, that was because of multiple lesions. Little did anybody know at that time that this might have a different connotation in this disease, and truly what we are talking about today is multiple myelomas. And myeloma is not one disease, and as we study and understand more and more about the biology of this disease, we understand the heterogeneity that underlies this disease, and we know the patients don't always do the same way. Now, we have made a lot of progress in this disease. The survival of patients with multiple myeloma have tripled, if not quadrupled, in some of the series. And that is a testament to the therapies that we have available and the understanding of the biology. But we still have a big challenge in front of us because 25% of these patients are going to be dead in 3 years. And the task in front of us is to identify who these 25% of the patients are and how are we going to treat them differently so that they can actually have the same outcome as the remaining 75% of the patients. So what makes them different? To do this, we have to have a better understanding of the biology. We have made, again, a lot of progress in this. We know there can be difference in the tumor clone, which can be the underlying genetic abnormalities. We know there's some prognostic factors related to the tumor clone, like proliferation and the circulating cells. We know that host factors are very important in terms of the outcome in this disease. And you'll hear from Professor Morrow about how we risk stratify patients based on some of those host characteristics. And there are also factors that represent the interaction between the host and the tumor clone, such as the international staging system and some of the immune parameters. And there's a whole host of risk factors that have been identified and described, and we won't go into all of those, but want to base this discussion primarily on things that we do in the clinic on a day-to-day basis. The first question then is, why do we even bother risk stratifying these patients? We have good treatments, why don't we just give the same treatment to everyone? There are two important goals for risk stratification. One is we want to be able to counsel the patient, give a realistic expectation of what their outcome is going to be. And the second point, which is going to be the focus of the talk today, is how do we actually decide on the type of therapy we're going to give to a particular patient based on the risk status. Now, one of the biggest, if not the major drivers of the heterogeneity in this disease is the underlying genetic abnormalities. Now, when we used to do metaphase cytogenetics, only about 30% of these patients would have an abnormality. But when we started doing interface FISH, which does not depend on proliferating cells, we know that nearly all patients with multiple myeloma will have one or more abnormalities in their plasma cell clone by using FISH. Now, broadly, they can be translocations, which typically involve the heavy chain locus on chromosome 14, or they can be trisomies of odd-numbered chromosomes, with about 10% of patients having overlap of these two abnormalities. And on top of that, these patients can have overlapping abnormalities that include deletions of chromosomes 1, 13, 14, 17, as well as others. And the distribution that we typically see in patients are as shown here. Now, how does it matter what type of abnormality you have? Now, what we have seen from multiple studies, and this is just an example of our own experience, which has shown that if you have high-risk markers such as deletion 17p or 414 or 1416, then your outcome is much inferior with a median of survival of only about 3 years compared to almost an 86% 5-year survival when you don't have any of these high-risk abnormalities. Similarly, there's data from other groups, which more recent data showing that the chromosome 1 abnormalities can also have significant impact on the outcome of these patients. Now, Dr. Palumbo put together all these, the FISH abnormality data as well as the ISS staging system that we used to use before, and also the LDH, which we have known for years is a good prognostic factor. So the revised ISS staging system is really upgraded the traditional ISS staging system and brought it more current by adding the FISH and the LDH. So if you have an ISS stage 3 or a high risk by FISH or abnormal LDH, then these patients actually have a significantly poor outcome compared to those patients who don't have these high-risk markers. Now, the future probably may not depend entirely on the FISH or the LDH or all these other prognostic factors that have been described, but may use some of the more cutting-edge genomic technologies. We have some sense of this from some of the gene expression signatures that have already been described, starting with the GEP70 score from the University of Arkansas, as well as the HOVON signature, both of which are available on a commercial platforms. And we know that they do actually identify a subgroup of patients, about 15%, who have very poor outcome. And these technologies may help us make these prognostic features of the risk stratification systems more specific. We also have understood, based on some of the sequencing data that have come out in the past 5 years or so, that there is significant load of mutational abnormalities in patients with myeloma. Now, how do they affect the outcome? And this is some of the recent data from the Arkansas group, which shows that if you have mutations, for example, of the p53 gene, that usually portends a poor outcome. Again, mutations involving the DNA repair pathway can also be associated with poor outcome. So what we are learning now as we go deeper and deeper into the genome is we have other factors which may also predict the outcome of these patients. Now, the challenge in front of us is how do we actually consolidate all these different pieces of information into a risk stratification system that is easily available to everyone and can be used in the clinic to direct therapy. What is encouraging is that we actually have the tools to do that. We have increasing number of tools in terms of the therapeutic agents that we have. We have gone from the traditional drugs to the proteasome inhibitors, the IMiDs, the HDAC inhibitors, as well as the monoclonal antibodies. So how do we apply these tools to match the patient's risk? We can either use a specific drug because it is a mechanism that overcomes a specific risk factor. We can use a specific combination in a patient. We can also vary the duration of therapy based on what the risk status of the patient is, and we could also target a particular level of response. And we'll hear more about the MRD negativity later on today. Now let's talk about the use of a specific drug. And this, again, I won't go into the details of these studies, but multiple studies have shown that if you use a bortezomib-based regimen for initial therapy and continued maintenance, patients with 414 translocations do much better than what they have done historically. We have seen that also in the context of the 17p deletion. This is data from the HOVON trial, where you can clearly see that the patients who actually have a deletion 17p who got a bortezomib-based therapy and tandem transplant really had much better outcome compared to the patients who did not have access to the bortezomib-based therapy. Now, clearly we know that the combination therapies are what we're going to be used in the future, and especially the proteasome inhibitor IMiD combination has become the baseline for many of the initial therapy approaches. And this is data from the MRI which demonstrate that patients with deletion 17p or other high-risk FISH abnormalities, if you do induction with a bortezomib, lenalidomide, dexamethasone and continue them on the same therapy for long periods of time, these patients actually do much better than what we would have anticipated from the historical data. So again, here's an example of not just using a particular drug or combination, but also by changing the duration of therapy of that intense regimen, you're making an impact in the patient outcome. Now, this is the part which Dr. Rajkumar was gloating about, which was his right choice. So this is data from the European trials, which clearly showed that patients with deletion 17p or 414 translocation, if they got a tandem autologous stem cell transplant, their overall survival was much better than a single autologous stem cell transplant. Now, you will see some data from the Stamina trial in the late-breaking abstract section on Tuesday, where they showed that a tandem transplant versus consolidation with bortezomib, lenalidomide, dexamethasone versus directly going to a lenalidomide maintenance after a single autologous stem cell transplant are fairly equivalent, suggesting that tandem transplant may not be the best approach for everybody with myeloma. However, when you take into account the data from the European trials and the lack of cytogenetic data from the Stamina trial, I think the current recommendation, at least to me, is that again the high risk patients with deletion 17p, we should certainly consider a tandem autologous stem cell transplant. Now, the other part of the whole treatment algorithm is the duration of treatment, as we talked about with the bortezomib, lenalidomide, dexamethasone. And here, this is a meta-analysis that Dr. Palumbo published. And again, as you can see here, one of the most striking factors that you can see here is that patients with cytogenetic abnormalities actually had good outcomes when they were on continuous therapy. Now, the final point is the depth of response. And again, we know we are increasingly starting to use minimal residual disease assessment, but even in using the old-fashioned complete response, the data from the Arkansas group clearly showed that patients with high-risk abnormalities are the ones who clearly benefit from getting a very deep response. And there is comparable data with MRD negativity as well, suggesting that in these high-risk patients, the specific drug, the specific combination, the duration of therapy, and the target that you are going after in terms of the depth of response are all important. So knowing the risk status really does make a difference in what you select and what is your treatment approach. So is it time for risk-adapted therapy based on the genetic risk? We certainly have good risk stratification tools. We have several treatment choices that we can actually use for tailoring the therapy. And the emerging data does support use of specific approaches for addressing the risk in a given patient. Clearly, prospective trials need to be done, incorporating these questions right into the study design. But I'll stop there and thank you.
All right, so we're going to go ahead here. We will have a discussion, I guess, with the. I'm sorry, I was uncertain if we were going to go through to have the discussion at the end, but why don't we break it up and we can have some comments and discussion about risk based upon the genetics and LDH. So, do we want to have some comments about single versus double transplant, perhaps, Vincent?
I'm actually thankful that the audience agreed with me. 50% of the audience agreed with me. So, and I will tell you that I picked this answer for single transplant with bortezomib maintenance before I knew the stamina results. After the stamina results, I don't know why any of you still pick tandem transplants, so that you guys have to explain to me. But I will tell you, I will tell you why I chose the single transplant, because it is not, you don't take a case in isolation. I know more about the case than just the fact that this patient has a deletion 17p. I also know the patient became MRD negative after a single transplant. I cannot ignore that piece of information and just say that all I know about this patient is this is a high-risk patient, therefore I should do double transplant bortezomib maintenance. That's a recipe. That's not a approach to the treatment. For this particular patient who's already MRD negative after a single transplant, why would I subject that patient to a second transplant when the data for the tandem is not strong? It's not randomized data, it's just conjecture type data. And so I was willing to just go ahead with bortezomib maintenance, where at least I had randomized data that patients who got bortezomib maintenance with deletion 17p lived longer than patients who got thalidomide maintenance. And I also know that len maintenance did not work in patients with deletion 17p. That's the rationale. Now, after the CTN trial came out, I think the burden of proof is on tandem transplant. If you want to do tandem, now you have to show why the stamina trial doesn't apply to you. VRD, transplant, and len maintenance is my standard.
So, Philippe?
Well, that's always good to have discussions with Vincent, because from one side he's claiming that we need evidence-based medicine, and from the other side he's not using evidence-based medicine. So. But right now, in fact, we do have data on tandem stem cell transplantation based on the meta-analysis proposed by Michele Cavo, showing that for high-risk cytogenetics, tandem is better than single. And then Michele will show once again during this meeting, the results of the EMN2 study, the European study, comparing no stem cell transplantation up front versus single versus tandem. And I don't have the entire presentation available, and we should go and listen to Michele. But I think that tandem is doing better than single, and in this study, cytogenetics was performed for many patients. So we'll have the data regarding cytogenetics and tandem versus single. In the stamina study, I think that we will lack the data on cytogenetics, and the US trial will be not able to answer to this very important question. In addition, I am not aware of any data of MRD assessment and a treatment strategy right now available. We don't have any clinical data on MRD and then the selection of a specific treatment. So Vincent, I don't know what you are speaking about.
Okay. Well, maybe we'll go ahead and see what the audience thinks about that. Let's go ahead and ask the question again. Someone popped up there. Excuse me. Go ahead.
I would like to caution the audience about stamina data.
Okay.
The stamina data have a median follow-up of 38 months, which is very short. At 38 months, when we looked at our study in Total Therapy 2 comparing thalidomide to no thalidomide, we didn't see a difference yet. When the French did 1 versus 2 transplants, at 3 years there was no difference yet. So we are not interested at survival at 3 years. We need to know what's the 5, 7, 10 years survival. And you need to have much longer follow-up. And one of the disturbing things is that it seems to me that the stamina data are not going to be followed up after January of next year, which is not even 4 years of median follow-up, which would be strange.
Yes, indeed. Okay, thank you for that caution. Okay, let's go ahead and see what the audience is thinking about this choice.
I have a question here. Excuse me.
Okay.
Bo Björkstrand, Karolinska, Stockholm. I'm slightly surprised that not one in this distinguished panel of experts would consider an upfront allogeneic transplantation in this patient. Maybe this could perhaps be a good case for that. There are not very much scientific data, of course, supporting this because the allo studies were done before the era of the novel agents, but this is the young patients with high risk criteria with a very good response on the upfront treatment. Do you have any comments on that?
So who would like to comment on allo? No one really, I don't think.
I think the major problem with allo is the morbidity and mortality, and also the relapse rate that is also quite important. And on top of this, we have now the opportunity of, in high-risk patients, when they relapse after autologous transplant, we can choose many clinical trials with novel drugs. By contrast, if you have included the patient in an allo transplant program, you are going to have difficulties to include patients in the clinical trials with the novel drugs. And I think this is something to be considered when you have in front of you a 40 or 45-year-old person.
Key point. Vincent, last point?
So anytime you are engaging about a very aggressive form of therapy, we're not talking about giving 1 month of lenalidomide consolidation here. We're talking about allogenic transplant. We're talking about a second stem cell transplant. It is very important that the burden of proof and the level of evidence we require for such dramatic decisions be based on like solid phase 3 data. In the absence of which the default has to be always the more conservative approach because you could actually cause harm. Secondly, you need consistency of the association. That is what allo transplant lacks. There are some studies which say that patients who got an allo transplant live longer, but there are many which say they don't live longer. And so if there is no consistency of benefit in an intervention which is as rigorous and as involved as an allo transplant to a patient, that's very important. Yes, there are 1 or 2 studies which show allo it works, but we cannot cherry pick the data. There are many others which show that allogenic transplant has no improvement in PFS or overall survival as well.
Thank you.
All right. Thank you for that. Okay, so let's vote again. How do you feel about single versus double, all right? You've seen the case, high-risk case with the, we'll go forward to the genetic parts. You saw the abnormalities, and the follow-up testing, and the treatment, and then the choice for the follow-on treatment. So all the different options that we've commented on. So if you want to go ahead and vote it one more time, what do you think? Very calm music for this choice. Okay. All right, well, what can we say? So, a very convincing tandem argument, apparently. Okay, well, most interesting outcome for this first part of the risk assessment presentation. So let's go ahead. Thank you so much. What about changes that might be based on the age of the patient or the presence or absence of comorbidities? And, again, it is important to have the case first. There we go. All right, so there was a lot of discussion about how old was old. Should this patient be 68 or 78 or 88? And so I would just mention that the 78 came after a lot of discussion about, this is a 78-year-old patient, okay? With hypertension, diabetes, and peripheral neuropathy, some significant bone pain, anemia, elevated beta-2 at 5.8, a lot of bone disease, M-spike 5.2 grams, 42% plasma cells, clearly symptomatic stage 3 disease. And if we go forward here. So the first question is, for this patient, do you need the cytogenetic profile or LDH level before you would want to select your therapy? So what do you think? Yes, you need one or both, or no, you're fine, or you're unsure? What do you think? Fast answer for this one. All right, so we have a split here. Yes, you would need both, or no. Okay. We have a dichotomy here. You really need the information, or actually you don't. All right, well, Philippe, I think you may have some interesting challenges here to convince people. Let's go forward here. All right, so again, we have the faculty saying, yes, we would want both, all right? We're unanimous. Vincent is not splitting the vote in this case. All right. Are we ready here? Okay. The follow-on question that Philippe is going to be talking about, in addition to that information, would you actually do a complete geriatric assessment before you would start therapy? Would you assess functional status, comorbidities, and the like by some tool? Yes or no, or uncertain? Much stronger music now, yes. This is a very important decision. Okay, so geriatric assessment, yes, very important. All right, so Philippe, I will turn it over to you at this point to, oh yes, first of all, this is kind of interesting. Sorry about that. Yes, we do have a little bit of a split here. So we have a complete split, as a matter of fact, yes. So we'll have to discuss that later, for sure. Oh, we also go ahead to select the treatment. Having received the risk information or done your geriatric assessment, yes or no, maybe not, how would you actually treat this 78-year-old patient with the features that were listed there? And you can see here that you have several options for triple therapy, including bortezomib, one with carfilzomib, cyclophosphamide, cyclophosphamide ixazomib, or a doublet lenalidomide and dexamethasone. And so clearly quite a range of options here that you could consider for this elderly patient. So you have the unsure category here as well. Oh, okay. So what do we have here? All right, so we have a dominant answer, which is Lendex, with a follow-up of VRD or VMP. So what did our faculty say about this one? Lendex. Okay, so we have a little bit more concordance here, not so much to explain away. All right. Philippe, why don't you explain to us how should we treat our elderly patients? Please welcome Philippe Moreau.
Thank you, Brian. So we are going to discuss the treatment of elderly patients, and this age distribution is very important to keep in mind when treating our patients. You can see immediately that we are going to speak about more than 60% of our patients above the age of 65. And when looking at the guidelines that are proposed in Europe or in the US, the first option when patients are not eligible for stem cell transplantation is to use either VMP, one of the standard of care, especially in Europe. Lendex is also approved in US and in Europe. MPT will be less and less used in the future, and we are going to discuss this study comparing Lendex versus MPT. And we do have strong data supporting the use of RVD upfront based on the SWOG study that was reported last year at ASH by Brian Durie. So MPT was widely used in Europe, and you know that we do have 6 randomized trials that have compared MP versus MPT, and there is a true benefit in terms of PFS, but also in terms of overall survival on a very large number of patients analyzed, showing that MPT is better than MP. So that's one of the possibility to treat elderly patients. Of course, you are all aware of the VMP results that were presented several times with a very long follow-up, showing a benefit not only in terms of time to progression, the primary endpoint of the study, but also, and more importantly, in terms of overall survival. So VMP is another possibility. During this meeting tomorrow, Dr. Facon will present the update and final analysis of overall survival of Lendex continuous treatment versus Lendex 18 or MPT. These results were presented last year at ASCO, but we will have the very final results showing that Lendex continuously is better in terms of overall survival as compared with MPT. So this is the reason why we are going probably in the future to use Lendex and MPT. The use of MPT will decrease for sure in many countries. What is the future? And we can anticipate another change in the landscape of treatment of elderly patients frontline. If we want to use in the future MPT-based treatment, this study is ongoing. The Allogeneic study comparing VMP versus VMP plus DARA. And we already know the winner, although the study is ongoing. In the future, we are going to use Len-based strategies, and 3 trials are very important. Some of them are closed for enrollment, such as Tourmaline, comparing Lendex versus Lendex plus ixazomib, an all-oral triplet regimen. We will have next year the results of Lendex versus Lendex plus ELO, ELOQUENT 2 study. We also have this ongoing Lendex versus Lendex plus daratumumab study, the MAIA trial. Interestingly, the Spanish group proposed a combination of two regimens that are very effective, Lendex and VMP, and this paper was published by Marivi Mateos last year. And last year again, the VRD regimen was proposed as one of the standard of care. This is the Spanish approach, the total therapy approach for elderly patients, and in a phase 2 studies on a very large number of patients, more than 200 patients, they have proposed VMP 9 cycles or Lendex 9 cycles, the sequential approach, or an alternating schedule of VMP and Lendex, 18 cycles, a fixed duration that, to my opinion, is very important for elderly patients. And the results are very, very good. These are the results in terms of overall survival, no difference. When comparing the sequential and the alternating schedule, the overall survival is very good, the best ever reported for elderly patients with a fixed duration of 18 cycles. So this can be easily done in your routine practice as well. And the SWOG study was presented last year, currently in press in the Lancet on a very large number of patients, 8 cycles of RVD versus 6 cycles of Lendex, but the same duration, and in the 2 arms of the study, the patients were receiving subsequently Lendex maintenance until progression. And the results are very good for the VRD regimen in elderly patients not eligible for stem cell transplantation. You can see a huge impact of the combination of the addition of bortezomib, showing the synergistic activity of bortezomib in addition with lenalidomide, and the median overall survival was quite impressive, 75 months in median, and the Lendex arm, the median overall survival is 5 years, very similar to what is observed in the first study that will be presented tomorrow. So many options, VRD, VMP Lendex alternating, or Lendex alone. So can we use this for all patients in the routine practice? Probably not, because we have very often to reduce the dose of our treatment proposals because the patients and the elderly populations are often very frail. So this concept of the adjustment of the doses of treatment was introduced first by Antonio Palumbo in Italy, and we know perfectly for young patients fit without comorbidities, stem cell transplantation, at least in Europe, Frontline is remaining the standard of care. When patients are becoming older, but they are fit without any comorbidities, in good clinical condition, we can use full dose novel agents-based strategies. But in elderly patients or patients with comorbidities, we have to adapt the dose and to reduce these novel agent-based strategies. This concept was developed but needed confirmation, and recently, last year in fact, the International Myeloma Working Group proposed a systematic geriatric assessment to predict survival and also to predict toxicity in elderly patients with frontline treatment. And I'm very surprised that Shaji Kumar, who is one of the authors of the study, and Jesus San Miguel, who is also one of the authors of the study, proposed that it was not necessary to have a geriatric assessment. Did you read the paper? We'll speak about this later on. And I will tell you why this is very complicated to perform in a routine practice. So 27 experts and claiming that geriatric assessment is mandatory. So let's look at that. This is the frailty score that is proposed to evaluate systematically all elderly patients. It is based on 4 criteria: age. The second one is the Charlson Comorbidity Index. The third one is ADL score, activity daily living. And the fourth one is IADL, Instrumental Activity Daily Score. And then, if you are younger than 75, you have a score of 0. Older than 80, you have a score of 2. If you have a poor Charlson, a score of 1, etc. This is an additive score, and you are adding 0 plus 1 plus 1 plus 0, and then at the end, you can segregate your patient as a fit one if the score is 0, an unfit one if the score is 1, or a frail patient if the score is more than 2. This is very important, in fact, because this study was based on the analysis of more than 800 patients treated with various regimens, including VMP, including Lendex, and when looking at survival subgroup analysis, age was, of course, a very important prognostic factor. Chromosomal abnormalities was a very important prognostic factor as well for overall survival, and frailty was the most important prognostic factor to predict overall survival. And once again, almost 900 patients were enrolled into the study to confirm that we were needing a geriatric assessment. When you're looking at overall survival for fit patients, the survival is good. On the opposite, frail patients, the survival is very, very different. And in the middle, you have the unfit patients. When looking at the discontinuation rate of treatment, this is very similar. The fit patients are able to stay on treatment. On the opposite, frail patients are not able to receive the treatment. For 1/3 of them, they have to stop and discontinue therapy within the first 6 months of treatment. And also, this patient population of frail patients is associated with a higher number of adverse non-hematologic events. But to go back to this score and to this index, what is ADL? Do you know this really? Are you doing this in your routine practice? I understand that Jesus is saying, no, I don't need, in fact, this geriatric assessment, because he's never asking this to his patient. This score was developed quite a long time ago, 1963, probably one of the best years. Well, you know why, Vincent? I was born in 1963. So when you want to assess the ADL score, you are asking 6 questions to your patient. Are you able to do your bathing, your dressing, your toileting, transferring, continence, and feeding? And then, if you have more than 4, yes, 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 and yes, your patient is adequate with an ADL score of 0. So this is very simple, but you need to know these questions. And I understand that Shaji probably said, no, I'm not doing this in my routine practice. That's a lot of questions, a lot of time. And in addition, when you're looking carefully at the paper, you need to assess this in front of your patient only, and not the patient plus the family. The patient plus the wife, or the patient plus the husband, because the wife is always answering for your patient, whereas the patient is a male patient. You know this? And the patient will say, okay, I'm always okay, always, well, dressing, yes, I can do. Bathing, of course, I can do. And you don't know exactly if it's right or wrong. So this is not that simple. It's just the point. What is the second item? IADL. 8 very simple questions as well. Are you able to phone? Are you able to do your shopping? Are you able to prepare your food, etc., etc.? And then the patient will always say, oh, yes, yes, I can do this, of course. But is it really true? You need to assess this very, very carefully by people that are experts in this assessment. So you cannot do this as an oncologist or an hematologist in your routine practice. What about the Charlson Comorbidity Index? That's a very simple index, published quite a long time ago, but you have to consider all these items to have a score of 1 or 2, etc. So, for our patient, for example, a mild diabetes without any organ end damage, the score is 1. and our patient as well had a moderate renal disease. Her creatinine clearance was 40. So score of 1 plus 2, the cutoff is 3. So the patient has a poor Charlson comorbidity index. So this is the conclusion. We need to assess this systematically, the age, Charlson, ADL, ILDL, and then, according to your score, additive total score of 0, 1 or 2, you're fit, unfit or frail. And then, if the patient is fit, you can go full dose of lenalidomide, of bortezomib, dexamethasone, cyclophosphamide. On the opposite, if the patient is frail, you have to reduce the dose of len, to reduce the dose of bortezomib, of dexamethasone, cyclophosphamide, etc. And in the paper published by the International Myeloma Group, all the dose adjustments are proposed for each drug, dexamethasone, melphalan, thalidomide, lenalidomide, etc. So for our specific patient, the patient was frail. He has a score of more than 2. And in fact, you have to do the slow go. And the dose of dexamethasone, for example, is 10 milligrams per week, and not 20 and not 40, according to the proposal of this very interesting panel of experts. So the choice, the good choice, was len with very low dose dex. So I was the only one to say len, very low dose of dex. So now this presentation is open for discussion.
So thank you for this very educational presentation. We are all learning now how we need to be more careful in the clinic.
Ryan?
Yes.
May I?
Of course.
Okay. There are two main reasons why I didn't use the frailty score in this patient. The first one is because in the clinical history the patient was 78, diabetes, hypertension, plus creatinine clearance is already, I don't need to do anything else, is a frail patient. This is the first. And the second explanation is more robust, and is because I was very disappointed with Antonio Palumbo, that was the leader of the paper, because he didn't want to include, he included the Charlson and the ADL scoring system, but he didn't want to include the San Miguel scoring system for frailty. And the San Miguel scoring system, when I was in Salamanca, was very simple. I was sitting in my office, and I used a loudspeaker just to call the patient, Mr. Gonzalez, 1, 2, 3, 4, 5. Mr. Gonzalez. And the patient was coming, frail. But Antonio didn't want it.
Okay. So you have a choice of systems, as it turns out. So do we have comments from the panel? I don't see anyone up to ask questions on this at this point. Any? Shaji, do you want to explain yourself?
Sure, yeah. So I just want, other than the San Miguel score, of course, but I think the purpose of the paper and the practical applications, we have to think about it in two different ways. I think the manuscript clearly demonstrates, yes, a risk frailty assessment. Frail patients will do better with the dose modifications, and that is the message that Dr. Palumbo had. But as Dr. San Miguel said, you don't need all those variables to be done for every patient to decide whether its patient is frail or not. So you have to use some of the clinical judgment, how the patient looks in front of you, and maybe a simple thing like an ECOG performance status can give you most of the information you need for dose modification in the patients.
All right. So we'll see what the audience thinks about that. Any other further comments? I want to move. Jean-Luc, you want to make a comment? You have to go back, I'm afraid. Yeah, sorry.
I'm not afraid, so I can do it.
3, 4, 5.
Mr. Aruso. I just want to follow up on Shaji's statement because I think that Thierry Facon did perform a comparison between the frailty score and the ECOG score on
yes.
the first trial, and there was no difference. So sometimes it's easier to use, if you don't have a geriatric team to perform this finally very difficult staging with the ADL, IEDL, that we have no time to do in our clinics. If you don't have this geriatric team, very often the clinical experience and the ECOG score will be enough to define who is frail and who is not.
All right, thank you. Yeah, go ahead.
Sorry, as the last author of the paper that Dr. Palumbo wrote, I do have to make a couple of comments on why we wrote the paper. There's one is that clearly when we do clinical trials, it's not easy for somebody to just say, oh, I thought the patient was frail. So we really need strict criteria when we are proposing different dosing schedules and clinical trial assessments. So one of the main purposes of the paper was to establish the framework which can be used for inclusion-exclusion criteria in clinical trials. In terms of clinical practice, I do agree with what my colleagues are saying. If it's very obvious to you, you don't need to do a score. But there are some patients in whom you as a physician are not going to be capable of assessing frailty that easily. Then you do need the scoring system, and it's not that complicated to do. And then the final point is that patients over the age of 80 are automatically classified as frail without doing any further scoring. So this is only for patients who are, in the gray zone where you're not sure. So if the patient's age is over 80, you will meet the criteria for frailty in the scoring system. Thank you.
Okay, good points there. Okay, so let's go ahead and ask the questions again. It doesn't seem to be advancing for some reason. Okay. So I think that we understand this patient, 78 years old, and the different risk factors that Philippe re-identified for us. So if we go ahead here. So we'll ask again the cytogenetic and the LDH of value or not. We didn't really talk about that as much here, but let's see if there's any change. I think not any change here. Yes, we said both. Very similar, 40% said no. I think actually we didn't talk about it much and nobody really changed their opinion, I don't think. All right, so let's go ahead to the second one. Geriatric assessment, okay. Yes or no here? We, with bated breath, are waiting to see. Oh. All right, so interesting split, 2/3. A little improvement, so don't take to recommendations too well. Okay, very, very good. And then how would you treat the patient? We discussed some, Philippe talked about a number of the different options, so if you want to reconsider that and vote again. All right. Computer's thinking. Okay, so Landex. Okay. Very good. Yeah. So we don't have on the answer if it is the very low dose, Philippe. So we didn't sort that out, but Landex a major choice. All right. Well, thank you for that. We're going to go forward to the next topic, very important in the last few years, the role of maintenance in clinical practice. So let's go forward with this. We'll have the case first. So this is a case of a 65-year-old man with significant myeloma, 60% plasma cells, 3.5 gram spike, a high LDH, ISS stage 3, a 414 translocation, and he went into the SWOG trial and received the VRD and was in CR at the end of induction. MRD was assessed and was found to be positive at 10 to the minus 5. Okay. So what would you recommend now? This is a patient who's had a good response but is remaining MRD positive. So would you observe? Would you go ahead with lenalidomide maintenance for up to 2 years? Lenalidomide until progression? Bortezomib for up to 2 years? Autologous stem cell transplant with following up with lenalidomide maintenance? Or an autologous stem cell transplant with bortezomib maintenance, or obviously unsure. So what do you think for this patient who had a pretty good response but remained MRD positive? All right, so this could be interesting, I think. Okay, so in this case we have E is the winner, which is to go ahead with an autologous stem cell transplant followed by lenalidomide maintenance. And so certainly the basis for the IFM study that was presented last year, 30% saying that they would use bortezomib as maintenance for this particular patient. Okay. What we have here, we are unanimous on this one. We would do the transplant and use lenalidomide. Oh, sorry, except for Vincent. Okay, so sorry. Bortezomib maintenance. Okay, again, you'll have to explain yourself here, Vincent.
I will after the talk.
All right, I know. Okay, so Jesus, please welcome Jesus San Miguel to lead us through the discussion about maintenance.
What is the arrow? The arrow? Oh, yes. There you go. Okay, good afternoon, everyone. How do you move the slides? Here. Oh, here. Yeah. Brian, just before going into the data, let me share with all of you what is the concept of consolidation and maintenance. Consolidation is a treatment, a short treatment that you give to the patient after the transplant with the goal to improve the response, while maintenance is a prolonged treatment with the goal of maintaining the response, achieving following therapy. Is this concept of maintenance new? The answer is no. We already in the 90s used maintenance for the treatment of patients that were transplanted with interferon maintenance. And in the very earliest of the 60s and the 70s, following melphalan prednisone, we continue with melphalan for many, many cycles. Then we realized that this was associated with an increase in second malignancies, and we decided just to have a fixed time. But at the beginning, maintenance was used both in the transplant setting and also in the elderly population. What I'm going to do now is to review the data on maintenance, first in the transplant setting and then in the non-transplant setting. What about thalidomide after transplant? There are 6 randomized trials that has compared thalidomide plus minus prednisone versus nothing. And in all of them, there was a benefit in PFS, but only in 3 of them benefit in overall survival. How much was this benefit? small, 6 months median. And this was also associated with quite high toxicity. This is probably why most of the patients stop the treatment and is not considered probably anymore as a standard of maintenance. What about bortezomib? After transplant, we have 2 trials in which bortezomib has been explored. In the first one is the HOVON trial. After PAT, bortezomib, adriamycin, dexamethasone, transplant, bortezomib was used for maintenance. And in the control arm, instead of bortezomib PAT, they used VAD. And instead of bortezomib maintenance, they used thalidomide maintenance. In this study, there was a significant benefit for the experimental arm in terms of PFS and also a borderline benefit in overall survival. However, it's very difficult to dissect if the benefit here comes from the maintenance with bortezomib versus thalidomide or the PAT instead of the VAD. It's different the situation in the Spanish trial, in which after induction, patients were equally randomized to receive either bortezomib thalidomide or interferon for 3 years. And this study has shown that this is the update data that has been recently submitted for publication with a long follow-up. Now we saw a significant benefit in PFS for bortezomib thalidomide as compared to the other 2 arms, but no difference in overall survival. Probably the situation is much more clear with lenalidomide maintenance. We have 3 randomized trials after transplant in which lenalidomide has been investigated against placebo, and all the 3 show a significant benefit, around 1.5 years improvement in progression-free survival. This was associated with increase in second primary malignancies, 2-3 times higher, and in one of the studies there was no difference in overall survival, while in the 2 other studies, the American and the Italian study, there was a benefit in overall survival. We have now the information that was presented at the last ASCO meeting by Michel et al. On the meta-analysis on overall survival of these 3 trials, the IFM, the American trial, and the Italian trial. And these long-term analyses show, after a median follow-up of 18 months, a clear benefit in overall survival. There is a 26 reduction in risk of death, represented an estimated 2.5-year increase in median survival. And this benefit was observed in all the groups. However, the benefit was not so clear in stage 3 and also in patients with high-risk cytogenetics. And this may indicate that in this cohort of patients, probably other approaches should be needed. In this meeting, we are going to have also information about maintenance based on the UK trial. That the UK trial included a very large number of patients treated either in the intensive pathway that included transplant or the non-intensive pathway, elderly patients, and they randomized patients with no maintenance or maintenance with lenalidomide plus minus bortezomib. The results that will be presented in this meeting indicate clearly superiority of the maintenance arm in terms of PFS as compared to no maintenance, both post-transplant and in the non-transplant setting. There is a 55% reduction in risk of progression of death, and this benefit was observed across all subgroups. Therefore, we have already 5 randomized trials based on lenalidomide maintenance that show impressive benefit in terms of PFS and already benefit in overall survival in the meta-analysis. However, as I already mentioned, there are some caveats for some subgroups, high risk, advanced stage, and probably now the critical question that I will address at the end of my presentation is, for how long the maintenance? Only lenalidomide, or should we add in some subgroup another drug? Now, let me move to the elderly patients. Is there any role for maintenance in the elderly population? First, again, lenalidomide. We have 3 randomized trials that compare MPT versus MP, and in the MPT arm, they used thalidomide maintenance. In these trials, no difference in overall survival was observed. The benefit in time to progression was relatively small, 4 or 5 months. There are another 2 trials in which thalidomide interferon versus interferon has been compared as maintenance, or thalidomide versus no maintenance, and none of these trials showed a benefit for prolonged treatment with thalidomide. What about bortezomib? The Italian group, Antonio again, has designed this trial in which VMPT followed by BT continuous therapy was compared with VMP. And as you can see, a significant benefit for VMPT plus VT was observed in terms of PFS and overall survival. However, it's not easy to dissect if the benefit comes from the continuous therapy with bortezomib thalidomide or the quadruplet combination used upfront, similar to what happened with the HOVON trial. The Spanish group, after a short induction with either VMP or VTP, we randomized our patients to receive bortezomib thalidomide maintenance for 3 years or bortezomib prednisone for 3 years. This maintenance was able to increase the response rate, the CR rate, and no significant difference between bortezomib thalidomide versus bortezomib prednisone. And what this indicates, that again, this corresponds mainly to thalidomide, no clear difference between thalidomide maintenance versus prednisone maintenance, in this case, in collaboration with bortezomib. What about lenalidomide maintenance in the elderly? The MPR trial showed that patients received continuous lenalidomide after MPR were associated with 18 months benefit in progression-free survival, but no difference in overall survival. As Philippe has already mentioned, in this meeting, we are going to see the update information on the first trial that compare lenalidomide dex continuous versus 18 cycles versus MPT. You can see that there is a benefit for the continuous treatment, and in this meeting, we will see that the RD continuous is superior to MPT for PFS and also for overall survival. However, no difference in overall survival will be presented when compare RD continuous versus RD 18 months. And in fact, this was also presented by Philippe, the Spanish approach, that instead of using a short 9 cycles in the elderly population, we are now using 18 cycles, but a fixed period of time, 9 cycles with VMP, 9 cycles with Lendex, with very good results as an alternative to the continuous treatment. Then my final questions to myself is, what is the optimal maintenance therapy? I think maintenance is clearly in the young patients in the transplant candidate, but I am not sure about the number of agents, as I mentioned. And I am not also sure about the duration of treatment. Here you may use lenalidomide single agent in combination with DEX, in combination with proteasome inhibitors. And look, this slide. This busy slide illustrates what is the current clinical trials in which lenalidomide single agent in maintenance is being compared with lenvorinostat, ixazomib-len, ilotuzumab, carfilzomib, and also maintenance with ixazomib, without len, or daratumumab. Then these trials hopefully will contribute to help us to understand if there is a population of patients that benefit from dual maintenance or even triple, as in some of these cases. But probably about the major challenge is the duration of the maintenance. And let me share with you what is the Spanish trial that will be started very soon, hopefully, in which we will compare our new standard, VMP, followed by RD, 18 cycles, versus KRD plus minus DARA. Patients that not receive DARA upfront will receive DARA consolidation. And then comes the critical point. We will have in front of us patients that are MRD positive. And we will randomize the MRD positive to maintenance, in this case DARA plus lenalidomide, versus no maintenance. And we will have patients that are already MRD negative, and we will randomize. In other words, we want to know if you have a patient that after an optimized treatment like this one, still residual disease is present, does maintenance has any benefit in this patient? On the contrary, you have a patient that is MRD negative, and probably the temptation is, I will stop. But probably in this patient, there are occult cells in which maintenance could be a benefit. I think that these type of trials are needed in order just to answer the final question about the duration of treatment. And now it's my pleasure to invite Bruno just to elaborate a bit more on the minimal residual disease.
Thank you. So now it's my turn to talk about how should we monitor patients during maintenance therapy. And the first message that I would like to highlight is that it may be that in 2016, to measure response only based on the M component may not be enough. Because if we look carefully to the median PFS and OS of patients in CR, VGPR, partial response, all of them MRD positive, then you would see that, generally speaking, there are almost no differences. In other words, if you have in front of you a patient with a negative immunofixation, you wouldn't know if the patient is in true CR or a partial response until you do the MRD test. I should also emphasize that even though at the time we were using a low-sensitive MRD assay, the probability of reaching long-term survival was almost restricted to those patients being classified as MRD negative. I would say that this is particularly relevant among cases with high-risk myeloma. As you can see in the upper part of the slide, the achievement of CR translates into superior overall survival for all patients except those with high-risk cytogenetics. By contrast, to achieve MRD negativity translates into significantly superior OS for transplant eligible, ineligible, irrespectively of ISS, and in both standard as well as high-risk myeloma. Then, what does it mean to be MRD positive after induction before further treatment such as maintenance? As you can see in the slide, and again, really for MRD positive patients, irrespectively of whether or not they are in CR, further treatment, unfortunately, for a significant fraction of patients, does not produce actual benefit. Then what is the meaning of a positive MRD test after maintenance if maintenance is not until disease progression? And again, what you can see in the slide is that even ultra-low MRD levels in the range of 10 to the minus 5, 10 to the minus 6, they usually predict for a high risk of relapse happening during the first 2 years after maintenance has been stopped. Is MRD the only thing that we should be monitoring? The answer is probably no. You may have in front of you 2 patients that are MRD positive. They even may have the same MRD levels, but as you can see, time to progression may be significantly different based on the pattern of cytogenetic abnormalities on the myeloma cell. By contrast, there are patients that may show specific rare mutations that may do extremely well. And again, if you look into the design of this specific clinical trial, some patients received maintenance, others did not. Also, immune profiling. By taking advantage of the natural features of flow and using a single 8-color combination that was really devoted to monitor MRD, but because the information was there, it was possible to enumerate up to 15 different bone marrow cell populations. In other words, to have a glimpse of immune reconstitution. And using this information on a multivariate analysis, this allows you to segregate in between typical MRD positive MRD negative, but also to identify a small subgroup of patients that despite being MRD positive, they show high normal plasma cell recovery, a favorable immune profile particularly related to the B-cell compartment, and a time to progression that is at least different as compared to all the other MRD positive patients. In other words, it could be that in 2016 and for the years to come, we need to integrate next generation immunophenotypic as well as molecular techniques to offer new concepts in risk stratification towards precision medicine in myeloma. To integrate certainly the patient factors, genetic landscape, depth of response including MRD, but also the features of MRD clones, immune profiling, and all of these integrated into big data sets. Certainly, this is a very ambitious effort, and therefore the contribution of each and every one of you will be extremely important. Only if we accomplish this effort, we would be in a position to give the answer to this very important question: which are the maintenance strategies that are effective in patients with persistent MRD, so we can turn more and more unsustained into sustained complete remissions. What about MRD negative patients? In this slide you can see already by using a next generation technique, in this case flow cytometry, that the outcome of patients being classified as MRD negative looks very promising. There are only 2 relapses, and if we look into those 2 patients and we start analyzing the percentage of mast cells, also different B-cell precursors, you would see that those numbers are lower than the lower level of the normal range. Meaning that if you want to monitor MRD, you also need to check for the quality of the sample. And while checking for the quality of the sample, you not only need to check for the presence of specific cell populations, you also need to accurately quantify those cell populations. Beyond that, we are seeing more and more patterns like the one that is illustrated in the slide. In this case, a patient that achieved a CR after 3 courses of VRD, but showed high MRD levels, 10 to the -4. Then after 6 cycles of VRD induction, the patient was actually MRD negative, continued as MRD negative after high-dose chemo, but as you can see, after consolidation, there is MRD reappearance in the range of 10 to the -5. In other words, there is unmet need for continuous monitoring of MRD. A single picture, a single snapshot will not be enough. Also, most probably, the need to integrate cellular, either flow or sequencing, with imaging techniques such as PET-CT. And in fact, Philippe Moreau showed last year in Orlando that patients reaching double MRD negativity by PET and flow had a very promising PFS, 90% at 3 years. Fortunately, all these concepts have been included into the most recent IMWG criteria for response assessment, including MRD in myeloma, with accurate definitions of what means a sequencing MRD negative result, flow, imaging, and perhaps the most important concept of sustained MRD negativity. The time is now to come together, to have consensus, and to apply these criteria into more and more studies. I would stop here. Thank you.
So thank you so much for this analysis of maintenance, and what we need to do now is looking more closely at the impact of MRD negative, MRD positive. So any initial comments from the panel members on this topic? Any thoughts?
Explain my answer if you want.
Yes, okay. The first comment would be from Vincent to explain why he gave a different answer to the rest of us. So he wanted to give bortezomib versus lenalidomide.
Yeah, I first want to know whether Jesus would change his mind after hearing your talk. The high-risk patients did not benefit from len maintenance. That portion of the talk.
That's correct, and this is let me explain to the audience. In the analysis conducted mainly by the French group, when you compare the outcome of high-risk patients receiving maintenance versus no maintenance, there was a benefit for the maintenance arm. However, the benefit was less, significantly less than the standard risk. And in this group of patients, I think ideally you should combine a proteasome inhibitor with the IMiD, or to test the proteasome inhibitor by itself. But since we have no data for the proteasome inhibitor by itself, is why I don't include it in the answer.
Okay, so I'll tell you, there is data though. There are three reasons why I chose bortezomib maintenance. The first one is the meta-analysis, which is really robust. That included the studies which use current therapy. And what it found was not just there was no effect, it was actually the hazard ratio was on the other side of the line. For high-risk patients. Lenalidomide did nothing for high-risk patients in terms of overall survival. The second point is that there are 3 trials in which the high-risk patients have done better and almost as good as standard risk patients. And all those 3 trials use bortezomib maintenance. That is, one of them is Michele-Cavo's study. The other one is the HOVON study, which randomized patients from thalidomide maintenance versus bortezomib maintenance, and if you look at the outcome of the high-risk patients, it was almost nearing similarity to the standard risk. And the third one is the total therapy experience, where the 414 patients in total therapy 2, which did not include bortezomib, had quite a bad hazard ratio of 3, versus total therapy 3, which included bortezomib, but otherwise was very similar to total therapy 2. The 414s started to behave just like the 1114s. So I think, putting that together, I would say that if I have a high-risk patient and who's MRD positive right now after a year of triplet, I would rather go with bortezomib maintenance than len maintenance.
So I just want to make one point. So I would have probably said the bortezomib maintenance based on what we said, but I think this particular patient, if I had chosen bortezomib maintenance, Dr. Durie wouldn't have called me here for this talk because we would have been left with 524 patients instead of 525. This is a patient who is on a clinical trial of len maintenance, and I would not be willing to take the patient off the clinical trial and put them on bortezomib maintenance.
And I also would add that in that particular patient, the ideal maintenance outside of a clinical trial for me would be to offer len plus bortezomib.
Right, I think that's very reasonable. One of the concerns I have is that we now have these data, and in your slide at the end, Jesus, you showed all of the trials which are coming along, which are going to take many years to have an answer. So these data we're talking about will be the data that we have for some time.
Yeah. Probably neither you or me will be here.
Yes, exactly. Okay, so let's go ahead to maybe catch up a little time here. Let's vote again and see. This is the case with VRD, MRD positive. What would you recommend? And we talked about ASCT with lenalidomide or with Velcade. All right. Very quiet. Aha. So there's definitely a shift. All right. Very interesting, yes. So we need to double check this green check mark. All right, very interesting discussion. All right, so the last segment for the formal case presentations is the relapse area, and really a major increase in information with all of the different trial results and the new agents used in combination for relapse. And so certainly a number of questions to consider here. And so obviously we need the case first. So in this case, a 61-year-old gentleman playing golf regularly, very important, and is so that's probably all you need to know. No performance status in this case. X-rays, lytic lesions, MRI, so significant disease. Mild anemia, elevated creatinine, calcium beta 2 elevated, albumin okay. The spike is IgG kappa, 32% plasma cells. Important, you have fish of 414 fish. LDH is twice normal. So ISS 3, the new ISS also 3. So treated with a VCD, so Cybor D for 4 cycles, achieved a VGPR, then was transplanted with MEL200, bone marrow plasma cells 2% after that, immunofixation was negative, free light chain ratio normal, so this gives us a stringent CR. So this patient then went on to lenalidomide maintenance and stopped because of fatigue, side effects, and sustained a CR. Okay. 6 months later, however, patient complained of bone pain and relapsed. So additional M-spike findings, PET-CT positive, diffuse focal lesions, cytogenetic 414. Okay, so a patient who did reasonably well and then relapsed. That's 6 months later. So the question for this case is, looking at that treatment profile, how would you treat this patient now at this point of relapse? And so you can see here that we've listed several different options. You have some carfilzomib combinations, double and then triple with lenalidomide or pomalidomide, ixazomib, panabinostat, elotuzumab, daratumumab with lenalidomide, pomalidomide, bortezomib, and so this reflects the whole range of options that we actually have before us at this moment. So from this menu, what would you pick for this patient at this moment? All right, so this could be complicated and interesting. Yes, so the top score B, carfilzomib, Lendex. So this is obviously a patient previously treated with bortezomib. Second choice would be G, Dara, Lendex, assuming based on the very promising Pollux data, but a scattering of options there to consider. Okay. So this patient, here we go. So what did our experts pick in this case? So actually, you'd be interested that those are the two options that our panel mostly picked, either the Dara Lendex, the Pollux trial result information, or the carfilzomib Lendex, with a couple of us indicating either one would be okay. Okay. can go ahead here. So the patient was treated with KRD, in fact, so one of the things that you had selected, and achieved a VGPR with the KRD. So this is a VCD treatment, then KRD treatment achieved a VGPR, but then the patient progressed again with new lesions at cycle 17 with an increase in the spike. So VCD, KRD, and if we go forward here, what would you give to the patient next after this? So we have early relapse and then the next relapse. So what would you give for the second relapse for this patient? And you can see here we've shifted. You have pomalidomide options, daratumumab, elotuzumab in different combinations. The DARA, you can see we've given you several options in the DARA category. So what would you select at the second relapse? Oh, very decisive choice here. Oh. So what do we have here? All right, we do have a winner here, and the winner is Darapom-Dex. Yes, with a backup of E, which is the Dara-Velcade-Dex. So you have a choice of the twins, the Pollux or the Castor. So let's see, what did our panel think about this? Okay, so I think that we're in agreement here. Darapom, Elopom, Darapom. So mostly we have a pretty strong Darapom reaction here from the panel. Okay. So Philippe, do you want to take us through and try to sort out what we should do to try to pick the best option in the relapse setting? Please welcome Philippe again.
So it is becoming probably more and more difficult, or it will become difficult in the future to select the optimal options, in fact, the optimal option at the time of the relapse. And in patients at the time of the relapse, with 1 to 3 prior lines of treatment, very recently we had only 2 options, either Lendex or bortezomib-dex. And now with Lendex we have a number of phase 3 clinical trials that have shown a significant progression-free survival benefit with the addition of a third agent. So now we do have evidence for phase 3 large randomized studies showing that we can use Lendex plus Carfil, or Lendex plus Elo, or Lendex plus ixazomib, and recently we've heard about the results of Pollux of Lendex plus daratumumab. So this is Aspire, Lendex versus Lendex Carfil, 17 months in the Lendex arm, median PFS, 26 in the KRD arm, so a very effective triplet regimen. The hazard ratio is 0.69. There is no overall survival difference right now. The data are not mature, but nevertheless there is a trend for a better overall survival as well into this important study. You know perfectly as well the results of the Eloquent comparing Lendex at the time of the relapse, 1 to 3 prior lines of treatment versus Lendex plus Elo. The benefit is less important, with 15 months in the Lendex arm versus 19 in the Elo Lendex. The hazard ratio is 0.73, but this is another possibility, another option that was recently approved in the US and in Europe as well. This is Tourmaline, Lendex placebo versus Lendex ixazomib, 14 versus 20. The hazard ratio again is in favor of the triplet, 0.74. This is the only all-oral regimen available that is approved in the US and recently received a favorable opinion from the CHMP in Europe as well. And this is Pollux. You know very well the data. Lendex plus or minus DARA, and the DARA arm is significantly improved progression-free survival. The data are not mature for overall survival, but the hazard ratio is the best one ever reported in the relapse setting, with a hazard ratio of 0.37, with a 63% reduction in the risk of death or progression. So what is the best choice, in fact, for your patient? Are you going to use Lendex Carfil, Lendex Elo, DARA, or IXA? In fact, efficacy is the most important factor to select a specific treatment. PFS is always improved, and we don't have yet any overall survival data. But we always have to balance efficacy with safety. We need also to improve the quality of life. We need also to consider the cost of the treatment, and drug access is very, very important. And also, in front of a specific patient, we have to discuss with him regarding the convenience, and in this setting, the oral availability of a triplet combination is probably important. But we are always looking at the second-line treatment according to the choice of the frontline therapy and also to the duration of the first response. So all these criteria should be taken into account when selecting a specific Lendex-based combination. So you saw that in the Lendex arm, the PFS is changing from 16 months to 18 months to 15 months. So it means that the patient population enrolled in all these 4 trials is not strictly identical. So how to compare the efficacy for PFS? Maybe the best way is compare the hazard ratio, and you have here on this slide the different comparison of these 4 recent phase 3 trials for PFS, but also response rate and duration of response. Once again, overall survival is not yet mature, and we cannot draw any conclusion on this very important point. We also have to consider the burden on healthcare system and patients. This picture is very important to my opinion, because we are considering different route of administrations, IV or oral ones. The dosal schedule is totally different when comparing ixazomib with 1 pill per week or daratumumab with 1 administration on a weekly basis during the first 2 cycles, and then every 2 weeks for subsequent cycles, and then on monthly basis following cycle 7. With daratumumab, with carfilzomib, we are using the day 1, 2, 8, 9, 15, 16 schedule in 28-day cycles. So this is all, again, totally different. And if we are looking at the number of clinic visits based on 18 cycles, there is a change to 18 visits up to 96. This is totally different. So the burden for the patient is totally different as well. The administration time is also changing. In some cases, you need a premedication, and in other cases, you need a prehydration as well. So this picture is very, very important, because you will speak and decide with your patient in front of you for a specific combination. So when patients are progressing on Lendex, we are switching to a proteasome inhibitor-based regimen. And once again, we have already many options. VD, the conventional bortezomib dex, VD plus ELO, VD plus DARA, VD plus panobinostat, VD plus pomalidomide, tested in the randomized 007 study. We can use also KD, Carfil dex, instead of VD. And a very cheap combination, very effective as well, is the VCD regimen. So what are the evidence-based phase 3 trials comparing VD versus another combination? We have this panorama study comparing VD versus VD panobinostat, and the PFS in favor of the panobinostat arm, 8 months with VD, 12 months in median with VD panobinostat, and a very good hazard ratio of 0.6. We have this head-to-head comparison of KD versus VD, carfil versus bortezomib. The Endeavor study, more than 900 patients randomized, and you can see clearly that carfil is doubling the duration of response, the PFS, the median PFS, 9 months with VD, 18 months with KD, and a very good hazard ratio of 0.3. We also have the recent data from Pollux, recently reported at ASCO and published in the New England Journal of Medicine by Antonio, comparing VD versus VD plus daratumumab, and this outstanding hazard ratio of 0.39. Overall survival data are not mature, again, in all these phase 3 trials. So again, we can do this comparison of PI-based studies. VD versus VD plus ELO, that's only a phase 2 study and not a phase 3. VD versus VD panobinostat, VD versus KD, and VD versus VD DARA. And once again, we can play the same game of looking at the hazard ratio, response rate, etc. And you will decide, in fact, which option you are preferring for your patient in front of you. This slide is very important because you are not proposing exactly the same toxicity to your patients. And I mention here the grade 3 or 4 adverse events according to across trials. With Aspire, you can see clearly hypertension, 4% grade 3 or 4 versus Lendex. And I mentioned what is different as compared with the Lendex arm. Cardiac failure, 4%. Acute renal failure, 3%. With ELO, Lendex ELO, a very, very safe regimen, and we do have only 1% of grade 3 infusion reactions. With Tourmaline, the main toxicity is rash, with only 5% grade 3, so a very, very safe combination as well. And with Pollux, you have also this infusion reaction rate of 5% grade 3, but mostly during the first infusion. So what about panobinostat in addition with VD? What is the difference when comparing the two regimens? You have a high rate of diarrhea, 25% grade 3 or 4, fatigue 24% grade 3 or 4, and vomiting 7%. With KD versus VD, again, the same signal in terms of hypertension, grade 3 or 4, 9%, dyspnea 5%, cardiac failure 5%. So we can clearly compare Aspire and Endeavor with this signal for the cardiac toxicity and the renal toxicity of this regimen. And what about DARA plus VD? Infusion reactions as well, 9% grade 3, mostly at the time of the first infusion, but hypertension is significant in this study in the DARA arm with 7% grade 3. Some patients will progress, unfortunately, and beyond 1 to 3 prior lines of treatment, we do have some evidence-based to support the use of pomalidomide based on the 003 study comparing POM low-dose dex versus high-dose dex. The study was proposed to patients progressing on LEN, progressing on bortezomib, and the progression-free survival, the primary endpoint, was in favor of pomalidomide, but most importantly, this translated into an overall survival benefit, POM low-dose dex versus high-dose dex, 12 months versus 8 months. Very recently, a phase 2 study proposed the comparison of POM-dex versus POM-cyclodex. So a very cheap combination because you are adding cyclophosphamide, an all-oral regimen. That's a phase 2 study with few patients, but nevertheless, in the POM-dex arm, the PFS is 4 months, very similar to the 003 study. And with the addition of cyclophosphamide, 400 milligrams weekly, you are improving the PFS from 4 to 9 months. And to be honest, in my routine practice, I'm using very, very often this combination of POM-dex plus cyclophosphamide in very advanced patients progressing on LEN or progressing on bortezomib. Very recently as well, daratumumab was approved in the US and in Europe in very advanced patients, end-stage patients, progressing on pomalidomide, progressing on LEN, progressing on bortezomib, progressing on carfilzomib as well. And in this situation of unmet medical need, DARA single agent was able to induce a 30% response rate. Interestingly, on this very large group of patients, patients treated in the US in the Sirius study and in Europe in the Gen 501 study, overall 150 patients, there is a group of patients with stable disease. These patients were progressing on treatment, on their last line of treatment. They were refractory to their last line of treatment, but they have been able to be stabilized by DARA single agents in almost half of the cases. And when looking at the overall survival in this very advanced population of patients, you can see that the responders on the top here of the curve, the median overall survival is not reached, and many patients are alive 2 years from the onset of treatment. But the second group of patients, patients with a stable disease, are also benefiting a lot of daratumumab, and the median overall survival from this stable population of patients is 1.5 years. So that's why many of us would like now to combine these two drugs that are proposed in very advanced patients, combining pomalidomide and daratumumab. That was the choice of the majority of us, POM-DARADEX, in these young patients progressing following stem cell transplantation and progressing on Carfil, lenalidomide, and dexamethasone. And I would like to thank you for your attention.
So thank you very much, Philippe, for leading us carefully through these various choices. I don't know if there are any immediate comments from the panel. Maybe one from me. Are we all comfortable looking at the hazard ratios to try to compare these regimens? It's something that we haven't really focused on as much until we got these really good hazard ratios recently. Vincent, what do you think about that? You wrote an editorial in the New England Journal where you did emphasize this point.
Well, ideally we don't want to compare across phase 3 trials because of the reasons you said. The populations may be, even though they look similar, they're mostly previously treated 1 to 3 prior regimens, good performance status patients. They look similar. But there is a danger in comparing across trials, so we generally don't like that. The dilemma, though, is we have 6 phase 3 trials with new triplets, and no one is comparing the triplet against each other. So if such studies are not even planned, then it doesn't leave us with any other option other than to compare across hazard ratios, and that means anyone who's not having daratumumab is going to be at a loss. So I would encourage companies and investigators to really take a chance and compare head-to-head the regimens. Maybe at least we'll find out which regimen is more suitable for which patient population.
Right. Any other questions or comments? I also found it especially helpful to look at your summary of the toxicities, Philippe. Really some significant differences in terms of the burden of care, which we haven't really looked at so carefully in the past. Okay. If there are no other questions or comments, maybe we'll go through and let's vote again. So, as you may remember, we had this patient who was treated initially with Cybor-D and then relapsed and then was actually treated with KRD. So why don't you answer again whether you think the KRD was a good choice or what you would actually pick. A number of us picked actually the Dara-Lendex. So what do you think was really the best choice for this patient after VCD in this first relapse setting? Okay, so yeah, the Dara, very, very similar. Yes, so we had picked those as, what picked up this time was actually DARA, straight to DARA Pomdex. Okay, very convincing data. Use it right away. But this is a patient who had actually not received Revlimid before. So interesting there. But clearly very impressive data from the Pollux trial. Okay, and let's go forward. So after receiving the KRD, what would we pick after that? Let's go forward to the backup choice. And again, the number of pomalidomide options and then daratumumab combinations of different types. Let's see what we have here. Okay, I think a strong answer here. C, DARA Pomdex, and you certainly saw the data with that, and so pretty striking choice, but also DARA Velcade-Dex in this setting. Okay, so actually relatively clear cut despite all of the many options that we have. Okay, so as I mentioned, at the end today, what we're going to do is just try to capture some of the things that we've touched on through the meeting. Oh, there is one question. Excuse me. Yes. Go ahead.
Just a question. As many on the board that chose the daratumumab, pomalidomide, dexamethasone, could you please elaborate on the evidence basis for this treatment? Thank you.
So ixazomib.
Daratumumab, pomalidomide, dexamethasone in combination. Evidence for that?
Darapomdex in combination was never tested right now in a randomized fashion in a phase 3 study. We do have quite a large experience coming from the US, presented 1 year ago at ASH and also at ASCO with Darapomdex from Dr. Shari from New York, showing outstanding results in very, very advanced patients. So this is the one experience on more than 100 patients, in fact.
All right. Okay, so let me just take us through this last segment, and the main two parts which I mentioned already is that we'd like to give you some algorithms to take away, which Vincent will work through with us, which we hope could be useful for your practice, and then to touch on some upcoming abstracts here to be presented at ASH. And so for the first topic, what we discussed was the diagnosis of smoldering and active myeloma and the current status of the management in the high-risk setting and the need to be aware of evolving risk factors in making that decision process. And the idea that we need to consider treating as myeloma, but obviously clinical trials and observation for the two right-hand pathways there. So spend some time talking about this. What we did not talk about is this algorithm, which we'd like just to discuss a little bit in leaving today, is what really would be the current algorithm for frontline therapy, including the option for transplant, which we did talk about a little bit. And so, Vincent, do you want to take us through the frontline algorithm?
Sure, and again, the idea here is that there are 20 choices that you could potentially do for a newly diagnosed patient, but ultimately it comes down to you have 6 people here who see a lot of myeloma patients, have done a lot of myeloma studies. If we are not able to give you what exactly we would do if all factors were equal, let's say if one of us got myeloma, then it'll be very difficult to send a message that you can choose any of these 20 regimens. And what I've tried to do is look at the 6 most influential trials, or 5 or 6 most influential trials in terms of what we know, And I'd say that currently for newly diagnosed disease, based on the SWOG trial, VRD, if available, will be the default choice. We have to find some other regimen that beats VRD in a phase 3 head-to-head setting. So that's where I have for both non-transplant and for transplant candidate as the preferred choice. For the transplant candidate, once VRD is given for 3 to 4 cycles, transplant and then maintenance with lenalidomide for standard risk and bortezomib-based maintenance, that could be bortezomib alone or a bortezomib lendex regimen for high-risk patients would be, I think, what the data currently from all these trials that I've listed supports. There is an option based on the IFM study that the survival is still similar for the non-transplant arm, provided a delayed transplant is done at the first relapse, and that's in the gray box there. That is an option we give for patients who are not so keen on an early transplant right now. So for our transplant candidates, it's VRD, transplant, and then maintenance with either len or bortezomib, depending on risk. If the patient is standard risk and they really don't want a transplant, then it's okay to give 4 more cycles of VRD and maintenance because that has given equivalent survival. For the non-transplant candidate, VRD for a year and lendex maintenance as done in the SWOG trial would be the default. But there are some frail patients, as we discussed with frailty, that len low-dose dexamethasone is still the standard. And I'd like comments from the panel.
So, yes, go ahead.
Well, I think that in Europe, we are, for the non-transplant candidate, we are going to use lendex for many, many patients or VMP. RVD, we will be able to use RVD as soon as this combination will be approved, but that's a very good choice. So from the left-hand side part, that's quite good, to my opinion. For the transplant candidate, I think that VRD as well is not yet approved in Europe, but as soon as approved, it will be widely used. That's a very effective triplet combination. Balanced efficacy of safety is a very good one. And we are still proposing for all patients, if possible, stem cell transplantation up front, because the French study is clearly showing that the best way of reaching MRD negativity is with the systematic use of stem cell transplantation. Of course, we can propose VRD times 8 and delayed transplantation, but if the goal is to reach MRD negativity, and we've heard very, very good data from Bruno, and also Vincent mentioned this, right now, the best way to reach MRD negativity is to combine RVD and intensive treatment.
Yes.
Yeah. In Spain, since VRD is not approved upfront in the non-transplant setting, I'm talking, we use VMP followed by lendex, the 9+9, the 18 cycles. And RD in the frail, I will agree. Regarding the transplant candidate, again, we have the problem with VRD. We are using VTD, but the Spanish trial is VRD based. And regarding the maintenance for the high-risk patients, I think in the future an attractive maintenance will be to combine len with ixazomib, an oral proteasome inhibitor will be really very attractive in these patients.
Okay, very good. So then, just to remind you, we had a little bit of a discussion about the double transplant. And despite these data here that we commented on, I think that we also have what should be a worthwhile session is to go to this late-breaking abstract. Unfortunately, it will be on Tuesday morning, but I think there could be some helpful follow-up discussion to understand the differences between these 3 arms, to reponder the idea of a tandem versus single autologous transplant. I think we also had a healthy discussion about assessment of comorbidities, whether you call to the waiting room perhaps, or do a more formal analysis, but I think it was certainly helpful to look and consider the way that we manage these patients with adjustments up front. Then, of course, a key thing that was emphasized by Jesus and Bruno, this key question about assessing MRD positivity or negativity, and what do we do for these patients, and having some carefully designed clinical trials, and we use this as an example for that. And we really need this information to make decisions of no treatment for MRD positive or negative versus continuing with therapy. And as just was mentioned by Jesus, we have a lot of options which will take some time to sort out. Jesus was emphasizing the ixazomib options, which is obviously good because of the oral format. And we just have to wait and see. It'll take some time for those data to evolve. We touched on already, this is for those who may not have seen it, this was the editorial from Vincent that accompanied the Pollux study, using the hazard ratio to try to assess the comparison of all the different data sets that we have. And so I think one of the key issues that we touched on at the end is how do we handle relapse. And so Vincent, would you like to take us through a template for the relapse setting?
Can you click once more so we get the right hand?
You want me to just fill it in for you? There you go.
There you go.
Mm-hmm.
So, you know, again, I'd like the input from the panel members, but when you have like a ton of regimens in front of you and you have to pick something, ultimately we have to pick something for the patient. And if all factors are equal and the patient is equal performance status, equal risk, equal cost, safety, everything is the same, I think if the patient is not refractory to lenalidomide, my best judgment right now is DRD is the default. It has the best hazard ratio. It has only 10 more visits than ixazomib compared to 96 visits or something for carfilzomib. So I don't see why I would pick any of the other regimens unless the patient is allergic to daratumumab. So DRD is my default if the patient is not refractory to len. And if the patient is and again, the important thing to consider is what is refractory, because some patients are on 5 milligrams of lenalidomide, that's not refractory. They are on 5 milligrams or 10 milligrams of single agent lenalidomide as maintenance. I would still use DRD in those patients. Refractory means like refractory to full dose len. Or a full dose len-based triplet. And in those patients, the best data right now we have is dara, bortezomib, dexamethasone from the CASTOR trial. And so that's why I have put those in blue, recognizing there are many gray areas, many gray patients. There are patients who are frail who cannot take dara. So for frail patients, IRD or ERD or POMDEX or IPD would be reasonable. And as you said, based on cost, Cybo-D would be a very good option for patients who are refractory to lenalidomide. But again, I would encourage companies to really engage with the key investigators in the field and do head-to-head triplet comparisons, because otherwise, whether I do it or not, someone else is also going to develop algorithms like this, which basically all go with the hazard ratio, which may or may not be fair. But that's what will happen because we have nothing else to go with.
So are the panel comfortable with these blue boxes there? That's really a big shift in the management for our first relapse patients. So, Shaji, how do you feel?
Just a follow-up comment on the dose of len they're considered refractory to. I mean, if they are on a low dose of len because they just couldn't tolerate anything higher, I think that would still be considered. If they can't use the same high dose in combination, then it's the same outcome.
Yeah, I think my asterisk might be in the wrong spot. When I say refractory to len, it's patients who are refractory to full dose lenalidomide. If they're relapsing on off therapy, or if they're relapsing on small doses of lenalidomide or on bortezomib, I consider them not refractory to lenalidomide.
Except if they are down to 5 milligrams of len because they couldn't tolerate anything higher, then it's the same thing.
But the asterisk is in the wrong spot. It should be on the other side.
Okay. So Philippe, you presented these data. Are you comfortable with this algorithm, or?
Yes, well, in 90% of the cases I'm in phase with Vincent, so that's fine. That's a good proposal. Nevertheless, drug access is an issue. Even in, let's say, in Europe, we will not be able to use DARA, Lendex, or Veldex, DARA before the end of 2017 or 2018 because of the regulatory process, definition of cost, etc. So Well, drug access is a big issue, and here what Vincent is presenting is fine for the US right now, and only for the US. That's a pity.
So, Jesus, what's your reaction to this?
I support what Philip has said, that currently we have not access. I think data index, with no doubt, is apparently the best regime we can use. But at the time of relapse, I think it's also important to consider what type of relapse. If it's aggressive, I would prefer to use a triplet. If it's not an aggressive relapse, and in this context of the non-refractory, I will be comfortable to use KD instead of KRD, and then to use sequentially lenalidomide cyclodex, because if you put together what is the median PFS of KD, 18 months, plus the median survival of Lendex or Lendex plus cyclo oral, what was reported by the Canadian group, you will reach a median PFS, putting together one after the other, of over 40 months.
Okay.
And I make this comment particularly for some countries that will not have the same access to all the drugs.
Right. By the way, if people have comments about any of this, they can jump up at any time, and you can give us your different opinions if you like. There's a follow-on to this, which is the algorithm for subsequent relapses. And so, again, Vincent, you want to take us through the thinking here for those second or higher relapses?
Yeah, anything beyond the newly diagnosed or the first relapse gets very complicated, because there are too many options and too many variables that Dr. Moreau went through. You know, the cost, the access, what is the patient previously exposed to, what are they relapsing on, how long did the previous remission last, how was the response to the previous. There are many factors that go in, but I listed some just so that people don't forget the stuff that we haven't studied in phase 3 trials. Obviously, if the patient has got a second relapse but has never tried any of the first relapse options, and those can still legitimately work, that's one option. But there's a lot of PALM-based regimens which don't have phase 3 data, I agree, but have shown very remarkable phase 2 activity, and I think it'll be reasonable to try some of those. There are additional options like VDT pace. I still end up using VDT pace sometimes when the relapse is aggressive. Bendamustine regimens, we still burn through many of these regimens quickly in some patients. And then adding panabinostat either to a carfilzomib-based or another PI-based regimen is another strategy to consider, because ultimately when you're faced with a patient who's relapsing and is still in good performance status, it's worthwhile to keep trying to come up with regimens. And we have many other drugs in the pipeline, and maybe they'll be eligible for some of those clinical trials as well.
Two key principles I think to keep in mind is always try to go to a regimen which has a different class of drug than what they're relapsing on. And the second thing to keep in mind is many of these class of drugs can be reused, especially if they haven't seen it for a period of time. And Philip's done the retreat study.
Right, exactly.
Yeah. Before you move,
yes,
this is a recommendation for the American doctors, similar to the San Miguel Freite score that I recommend you to use. I will recommend you in late relapses one drug that you probably are not familiar with this drug, but is melphalan. You can use in late relapse here in the United States, because patients will be melphalan naive.
Yes. It will be a novel agent.
Is a novel agent.
Definitely.
But it's going to be more and more expensive, be sure.
Right. That's right. The price has gone up a little bit, yes. But yeah, good thought. Okay. So thank you for that. And so in closing, for these relapse patients, I'm going to just draw your attention to the abstracts here at ASH that are dealing with new drug combos for the relapse patients. So this first one here is really an interesting new observation from a Swiss group from St. Gallen, where they are using an AIDS drug, nalfinavir, which synergizes with bortezomib, and they are reporting a high level of synergy to overcome Velcade resistance using this combination. So I think that none of us have seen this before, and so this is an oral presentation on Sunday at the beginning of that session. So I think quite interesting to see. Yes.
What are your thoughts on using ixazomib in place of Velcade in these combinations following relapse?
Okay, a good question. I think possibly Shaji is in the best position to answer this, or either Philippe as well, maybe.
So I think, in terms of activity, when you look at the combinations, ixazomib, Lendex from the Tourmaline has really good activity. So I think a lot of it's going to be finally the balance between the convenience and the cost of the therapy, because bortezomib is going to become generic soon, so that is going to be, so that cost factor is going to be one of the considerations in decision. But in terms of the convenience and the safety, there is no reason why it cannot be substituted for bortezomib.
Okay, thanks for that. Okay, so this is just to give you an idea that there's significantly deep responses that have occurred with this combination. So personally, I'm quite interested to see the full details of this new combo that we have not seen before. Venetoclax, we had presentations last year. Shaji will present the follow-up of the 66 patients, relapse refractory, and really interesting to see the 40% response rate in the 11-14 population here. So quite interesting data with venetoclax. With the combination with Velcade Dex, Philippe will be presenting those data, and I don't know if you want to comment there, but actually quite impressive overall results here in this combination. Do you want to make a quick comment about that, Philippe?
Well, I think that the combination of venetoclax and bortezomib is a very interesting one. The rationale is to target BCL2, but also MCL1 with bortezomib, and we know that venetoclax is able to enhance the activity of bortezomib. And well, the results are very good in patients refractory to bortezomib. We are able to salvage these patients with the combination, so that's a proof of concept, and it needs to be validated in a phase 3 study that is currently ongoing, comparing bortezomib dex versus bortezomib dex plus venetoclax.
Right. So should we maybe be looking at some other combos with the venetoclax, do you think?
Well, Shaji maybe can comment on the single-agent venetoclax in translocation 11-14, because to my opinion that could be the first targeted treatment on myeloma.
Right.
Yeah. Clearly, I think that this is probably the first instance where we actually potentially have a biomarker-driven therapy in these patients. And the 11-14 is not necessarily the biomarker, but it's a clearly enrichment factor for some underlying biology in terms of the BCL2, BCL-XL ratios.
Right, very, very interesting. Absolutely. Then there will be several follow-up protocols on the selinexor that you probably are familiar with from the last couple of ASHES, but now there will be some more definitive data from the STORM trial, which is basically selinexor plus dex. And this is interesting because they have identified this subpopulation, which is patients who are refractory to len, pom, bortezomib, carfilzomib, as well as DARA. And so this actually does define an unmet need group. And so it's quite interesting to see the overall response rate here in both the quad and the penta refractory. Duration of response 5 months, overall survival 9.3 months. And so I don't know if any of the panel would care to comment on this. How does that look to you? Jesus?
Yeah, I think this is a very attractive compound because of the mechanism of action that is completely different, and what we need is drugs working in a different way if we want to eradicate the residual disease.
Right. And so in addition to the selinexor dex, there's this the STORM trial, which is selinexor Velcade dex, and again some quite impressive results in the refractory patients here. You can see a 58% response rate here. Numbers are small, but again, encouraging data with the Velcade combination. And you'll see down here, there are a total of 4 abstracts, Selinexor Pomdex, and also Selinexor Cardex, where actually there's some pretty interesting synergistic data with the carfilzomib combination here. And then finally, just there is a little bit of an update on the CAR T cell, in this case the CD19. This is from the UPenn group, as you know. They're reporting 3 rather longer VGPRs here, but this is out of the 10 patients. Certainly not a home run, and I think that we're all aware recently of concerns about the cytokine release syndrome, and so I think there's going to be a lot of discussion about the CAR T cell approach. So I don't know if anyone would care to comment on this. What are you thinking about the future for CAR T cells? We have these data now with the CD19. We also have some BCMA data that will be presented.
Yeah.
You want to comment?
Yeah. No, I think we were, all surprised when we saw the New England data last year on the CD19 CAR T cell in myeloma, because 99.95% of the myeloma cells in that particular case were CD19 negative. It has been claimed that this could be a precursor 19 positive cell in the experimental model that we developed several years ago. We were not able just to show that. Then for me, it's not the ideal target for myeloma. BCMA is completely different, and I think I will persuade the BCMA CAR T cells. Also, we should consider that the CAR T has more difficulties to be used than monoclonal antibodies, and probably that the challenge will be to use the BiTEs BCMA CD3 versus the CAR T cells.
Right. So Adam Cohen will be presenting from the same group the preliminary BCMA CAR T data, so that you'll have both the CD19 and the BCMA, and then there's also a BCMA antibody which will have preliminary data presented as well. So Philippe, what do you think about the CAR T cell approach? Do you think it's going to be a key approach?
I'm trusting really the bispecifics monoclonal antibody BCMA CD3. There are several ones, at least 2 or 3 in developments. Preliminary data are quite interesting. So the issue is how to develop these new drugs. Because in phase 1-2 trials, we are going to show results in very advanced patients in the unmet need, refractory to DARA, etc. That's fine. We will have good phase 2 data. But how to develop into phase 3 and to put them on the market? It will be very difficult, because we are going to say, what is the control arm? The control arm will be Lendex-Dara, for example, or Veldex-Dara, and it will be impossible to defeat Veldex-Dara or Lendex-Dara. So we need to work on biomarkers, on subgroup of patients that will benefit. So that's a huge amount of work.
Right. Okay, so I think that's yes. Those are the abstracts I selected, therapy-related abstracts that I thought would be of the most interest. Are there any others that you guys think were that you're excited to be seeing, that you are aware of, that you want to comment on? Therapy ones? No. Any other questions from the audience? If not, the open discussion would be if you want to leave right now or not. So. So we really appreciate your involvement today. Thank you.